Thank you. collected. And before you will start with your conference, 2 days conference organized for Dr. Rath and her team here in our office on the subject reducing transmission of vaccine preventable diseases, I thought that might be worth to give you an idea what we are doing here when it comes to the German region. And actually, I was wondering if you might be interested to get my perspective on health issues at European level, because I'm working here as a desk officer for health issues, social affairs, and financial affairs. And since the Union State speech given by the President of the European Commission, Ursula von der Leyen, back in September 2020, and months before the COVID-19 epidemic broke out, the issue of public health was quite, or in other terms, the setting up of a European Health Union was already on the European agenda. Along with the proclamation of the setting up a European Health Union, the European Commission tabled several legislative proposals in the recent years, all of them aiming to coordinate better health countermeasures to address the COVID-19 pandemic in Europe in the first place, and secondly, to enable the European Union and its member states to face together future cross-border health threats and to combat them. The most visible result of these efforts has been the very fast and successful development of COVID-19 vaccines, its production and distribution in Europe and across the world. Another outcome of these common efforts to set up a European Health Union has been the founding of HERA in 2021. HERA stands nowadays for the Health Emergency Preparedness and Response Directorate, attached to the DG Sante. You might be aware that HERA main responsibility is to ensure that the EU and member states are ready to act in the face of cross-border health threats. Its mandate covers, among others, the procurement and stockpiling of medical countermeasures such as medicine and vaccines. In addition, HERA promotes also the research and development of innovative, and affordable medical countermeasures for EU citizens. Another pillar of the European Health Union I'd like to draw your attention to, has been the adoption of the regulation on combating serious cross-border threats in 2022. Germany, as well as the other member states, are now implementing this regulation. And since the beginning of this year, in Germany, the federal government, together with 16 German lenders, such as Berlin, is developing a so-called National Prevention Preparedness Response Plan, covering all kinds of cross-border threats of biological origin, including communicable diseases, infections, and antimicrobial resistance. Something's a little bit difficult because I'm more used to talk in German about these issues, not in English. These three examples may give you an idea how high on the European agenda are health issues nowadays. This did not remain without any impact on the European funding programs. Apart from the well-known European research program, Horizon, with a total budget of around 96 billion euro for a period of 7 years, of which 8 billion are dedicated to health issues. The European Union, for the first time since its foundation, dedicated over 5 billion to the public health sector. This funding program is called EU for Health. And with the help of this program, the Commission is now able to support member states in their efforts to be better prepared for the next health threats. This only gives you a very small insight in the things happening here at European level. And to be honest, I wouldn't have made such a speech several years before, because there was not that much done at European level when it came to health policy. But the pandemic changed a lot, because nowadays every member state, every region is well aware that there has been done a little bit more. But actually, the pandemic was really the game changer, that now the European Union, and hopefully the next European Commission too, because they will, at the end of the European Commission, they will dedicate also not only money, but also a lot of initiatives on this particular issues. So I think you will have 2 days with a lot of work, and hope you will find and enjoy a little bit the time in our premises here in the office of the Land Berlin. I wish all success to you. And I have to say a little bit out for the person outside. I can't see them really here. But all the best to you and a successful conference. I wish you.
Thank you so much. Thank you for having us. I hope we can have fun. Thank you. So, Paula. A few words. So Paula is going to be next on the agenda, our project officer. And I can feel for her father has been very ill and Rome. This week she had to go there, and he's having 2 interventions exactly these students. So she's still committed to join us today remotely. And for the team of the ImmuHubs Consortium, she will also be available on Friday for questions and answers surrounding our final reporting and our internal reviews. So that's the compliment we found. We're very grateful. Thank you everybody for being here. And if you haven't heard what I would say, she was very impressed by how many women are here. So that's pretty rare with European events. No offense for saying that. You're all inclusive here, but I'm not really helpful. Thank you. Paula.
Yeah. Hello, can you hear me?
Yes.
So many thanks, Barbara. And now, good afternoon, due to the time, everyone. Indeed, it's really a pity that I could not join you all in Brussels for this final project event. The pandemic didn't help neither at the very beginning of the project to meet in person. On the other hand, I'm very happy to see such a high agenda, and among others, also the name of the Principal Advisor on Health and Crisis Management in DG Santé, Mrs. De La Mata. You will have the pleasure to listen to her tomorrow, and she's the most eminent voice of the Commission, indeed, that you could wish to have in this final event. ImmuHubs is now entering a very important phase. The consolidation of the project results in final outputs, and also the final reporting to the Commission. And from the side of ADEA, you can stay reassured that I will be next to you throughout the process. I gave already availability to Barbara for publishing something in the news sessions of ADEA website. And very important would be that the consortium, to see and to get the consortium view how now the project results could be scalable and sustainable beyond the project duration. I'm paying a lot of attention to these aspects because you need to consider the end of the project a starting point for several of your activities and several of your results. And we can do whatever in our hands to support you as an agency, and just for you to know that since 2021, I am the responsible of the portfolio, most of the actions and the grants funded under the portfolio Crisis Preparedness and Emergency Response. So that's why I listen with high attention the words from Berlin, from Mrs. Völpel. And if you see any chance that your project results can feed into other channels, please let me know. And if I cannot do myself, I will liaise communication with any of the team in the agency for makes this happen. So on behalf of ADEA and also on a personal side, I really would like to thank the whole ImmuHubs consortium, and not only the coordination team, of course, that I was the most in touch with, for the level of commitment and for the efforts that you all made to successfully reach the end of the project. All those efforts are much valued, even more valued, considering the challenges that the occurred pandemic posed to you all. And on the other hand, I believe that the COVID-19 pandemic could bring even an added value to your project results and the project you have implemented. And surely the situation made all of us more solid in our resilience capacity. So my congratulations to you all. So therefore, I like to think that this point in time represents a new life for many of the project activities. And of course, I wish you all a very, very fruitful meeting and interesting discussion. And see you again on Friday with some of you. And I will be very happy to go through the recording once this is available. Thank you very much again.
Where the camera is. I don't know who developed that. Okay, first of all, thank you everybody for coming. I think this has been a tumultuous 3 years with a project that started in the middle of a global pandemic. And I'm really, really pleased to see as many of you today here. I know we are between we have just the Catholic and Protestant Easter behind us. We're in the middle of Passover. And we have the Orthodox Easter coming up, which also is important to our friends from Cyprus and Greece and Serbia. So thank you all for being here, for making the effort. It's always good to see each other in person. I think maybe let's celebrate the fact that we can see each other in person, thanks, among other things, to the availability of vaccines. So let's get started with the actual topic. So I'm just going to give an overview of ImmuHubs project. Many of you know about it, some of you don't, and some of you will remember, wow, we did all of this, really? So let me get started with a little bit of an overview of how this was conceptualized and how we planned this from the get-go and sort of where we went. And tomorrow, I thought I was going to talk a little bit more about what Paola just mentioned, the question of sustainability, scalability, what can we do next? What did we learn from the design thinking exercise at the interim meeting already about where we can go after the project is completed? So as an intro, I was going to talk a little bit about how this is embedded in the mission on vaccine equity, which, as our WHO representative knows, is a big deal for WHO and the UN, but also for the European Union. And then sort of how the ImmuHubs project fits in this, how we prepared all of this even already during the proposal generation with the comprehensive literature review, which was the first of its kind on this topic, how we built these ImmuHubs on the ground, how we built a technology platform, and how the patient representation and the citizen science and the focus groups were extremely instrumental to what we're doing at every stage of the project. And lastly, how you can stay tuned on what comes next. So vaccine equity, as you all know, has become a big topic before the pandemic. The it has been exacerbated, I would say, during the pandemic, because these inequalities, not just on a country level, but also on a global level, have become paramount, I would say, and extremely obvious. And so we felt that to the depth of our initiative in starting this project, and WHO has put very clear guidelines forward for how we should work towards greater equity on vaccine access and availability. So while many people talk about, vaccine hesitancy and some people being more in favor and less in favor of actually using vaccines, another major issue is, are we doing our job to make sure everybody has access to A, vaccines, and B, science-informed vaccine information and consultation that could or should accompany the administration of a vaccine. So the ImmuHubs project took that to its heart, and I have to say the Vaccine Safety Initiative was tendered right before the onset of the ImmuHubs project to write policy briefing notes on the small topics of vaccination and the third European Health Programme, which was, of course, a huge topic. But that forced me to dive deep into policy and legal texts and to understand in a more positive way that the many, many approaches we have in Europe to vaccination can also be an advantage from an innovation viewpoint. We don't have one solution that serves all. We have many solutions with all their flaws and advantages. And let's learn from that from the ground up rather than just directing things top down. That was sort of the idea that was formulated in some of these policy briefing notes. And when this call for proposals came forward, we said, okay, that's it. That's what we were trying to say. Let's do it. Let's make it happen. So we formed a team with many, many partners, and just enough to be manageable, I would say. And we were on weekly calls throughout many months, as you may remember. Hello, Adamos. Thanks for arriving. There's still a seat up here and up front. Nobody needs to sit on the back. So we formed a team, and it was really neat to talk about this even before we created the proposal. What can we do? Get everybody's input. How much do we need as resources? How can we set up these sites in very decentralized locations in Europe? Who would be the most in-need populations in your country? And everybody who's in the room here contributed massively to this part. The deadline was a little bit postponed by the Commission, so we had a bit more time, which was great, and we continued with the literature review and everything. So the governance structure was built very early on, and the idea was to have a strong stakeholder forum, many of who are hopefully following us online today, because we couldn't fit everybody in the room. Then, of course, HADEA, which was formerly CHAFEA, so that change also happened in the first year of our project, and the External Advisory Board, which is a bit closer to the project, which is represented here by Mohammed from WHO, by Gary Finnegan, and you will see remotely from Vaccines Today, and then you will see remotely the representative from Families Fighting Flu, Michelle, Siddhartha, if he can drop in from his mission from WHO Europe, and then finally many of our other partners in the project. And Naveen Thakkar even will try to be here from India. He's now the president of the International Pediatric Association, so he will be heard tomorrow. So we built this team and also decided who the countries will be where these ImmuHubs will be taking place, namely Cyprus, Finland, Greece, Poland, Portugal, and Serbia in alphabetical order. As I mentioned, we built the External Advisory Board, and then we started very early on with understanding who are these difficult to reach population groups in Europe. This annual work program, which was put forward between 2014 and 20 for the third European Health Programme, this particular project, ImmuHubs, was part of the final year of that, 2020, which is written in 2019. So just before the pandemic. So this project was not COVID specific. It was about all the vaccine uptake in Europe on any vaccine, really. And as you all know, the council decisions on this matter in 2018 were triggered by massive measles outbreaks in different parts of Europe, where even the policymakers were wondering, wait, how can we have okay vaccination rates on a country level but still see these outbreaks in specific population groups. So that's where this term population groups really came from. Who are these little groups of people who share an ideological view or a geographic location or a socio-demographic challenge that prevents them from accessing the vaccines that should be available to them? So there were 3 projects in the same year, but also in a similar idea. One was focused on prison populations. That one is finishing with some delay. I think we got an extension, both of them in the fall, and you will see them if you go to the European Public Health Conference. They will be presenting there. So there were 2 projects, one focused on prison populations, one focused on recent migrants. And we were supposed to focus on all the rest. Which is, okay, who is all the rest? So that's what this literature review is about. Who is really falling behind on vaccines? Which population groups are having challenges, not just in the EU, but in the WHO European region? And what are the drivers and what are the challenges and what can we do to circumvent or overcome this challenge? This became part of a special issue in the journal Vaccines on Uptake and Equity in Times of the Pandemic, which I had been asked to edit for the journal, and it was a really interesting collection of articles. If you ever want to have a free afternoon and want to read yourself deep into the issues of accessing COVID vaccines during the pandemic, this is really interesting. It's from high and low resource countries, from different angles, from different professional backgrounds. I was quite pleased to see this entire collection. Some of our partners also published in this special edition, also the team in Israel that was part of the consultants to our project, and the European Academy of Pediatrics and others. So please make that your own. It's open access. Part of this became our joint publication, which is really an effort from the ImmuHubs project, and it, as I said, was the first literature review of its kind on trying to identify these difficult to reach population groups by means of a systematic literature review. The amount of journals that were reviewed were extremely high, above 10,000. And it was a massive amount of work done by 2 very young people I'll mention in a minute. So as you can see in this rather busy slide, we were distilling the drivers, the barriers, and the facilitators that could be identified from these different articles published over time. Key outpoints here were that we need to identify strategies for effectively reaching these population groups once we have identified them, providing early screenings, trying to get ahead of the game, improving the health monitoring specific and tailored to these populations, using new communication techniques, which is one big thing we're trying to do in the ImmuHubs project, using digital tools, using analog tools, supporting vaccine literacy specifically to these populations, and strengthening advocacy in the midst of these communities. These were core findings from this literature review that you all have contributed to that have driven the design of the ImmuHubs project as a whole and the outputs that we're seeing now. So I want to give credit to the young Vivi members who did this. Winifred Ekezi is from Nigeria herself. She did her PhD on internally displaced populations in Nigeria. Phenomenal work on their vaccine access. And the youngest member of Young Vivi, he started his first nonprofit on vaccine topics when he was 15 years old, making us all look kind of old. And he was a Stanford freshman at the time. He's now about to finish his college. Phenomenal. And he is the kid of Palestinian refugees. So there's that. Kudos to those 2 people who did a lot of the work, and we all chimed in towards the finalization. So the approach of the ImmuHubs was really, what is an ImmuHub? And this is a picture from the analog tool, right, where we explain to participants, what are you getting involved with here? It's a physical space where you and your family can meet experts and where you can engage with them, and with some digital games, let's say, simple tools that are fun and not just dreadful. As I mentioned, there were many different countries that were contributing to this, namely Germany and Belgium were really just on the coordinating side. Finland, Poland, Serbia, Greece, Cyprus, and Portugal had these ImmuHubs on the ground, most of them exactly 3, depending on these 3 core population groups that we had identified, which you can see in different colors here. So 3 for each makes 18, plus 2 immunization hubs that were specific to at-risk populations. So they are at risk by nature of their underlying conditions. So there was one for people living with HIV/AIDS in Greece, and one for children with asthma in Portugal. These are groups who should be extra well vaccinated, and sometimes they're not aware of their challenges, and that's why we have these 2 extra hubs. The other ones are either populations that are isolated because of their worldview, isolated because of socioeconomic constraints, or isolated because of some form of geographic challenge, being on an island or being in a remote region that isn't being visited, or where you have a shortage of doctors, etc. So the analog tool was the first thing they would see, maybe a flyer telling them what the ImmuHubs are about, and then if they decided to engage, they were presented with an analog tool, which we developed with Praxis, the NGO in Greece, and we basically looked at very simple graphical representation. What is an ImmuHub? What does it look like? It's only scientific. They're not trying to make money off you. They're not trying to take your data. So you understand sort of how simple and low barrier this thing is. And then there were a few questions on digital literacy. And the question, do you want to participate? If you do you want to participate with your own smartphone or using a tablet provided to you at the site, or do you want to have an interview with somebody and they enter your data? This was meant to accommodate different levels of digital literacy. We'll talk tomorrow about future things that we could do to make that even easier. So that was the big part. Also, it was important that we identified in the literature review that language barriers are one of the most important ones. So we pushed the limit on how many things can be translated in this consortium, as you all know. So all the chatbots we developed are in 20 languages that were identified by the consortium, and the analog tool was also made in these same 20 languages. So these are, again, the countries that participated. So this is, I think, the most concise summary slides most of this project that most of you have seen already. So the goal of this project was to have these 20 hubs to increase vaccine uptake among these most difficult, most challenging population groups in Europe. So really, we made life hard for ourselves, we can say that, on purpose. Reducing transmission ultimately of these vaccine preventable diseases, prevent these little micro outbreaks that can cross barriers and borders quickly, as we know. And then to look at these specific populations and see why they don't have enough access to vaccines and how we can tailor to these different types of challenges that I mentioned, cultural, geographic, or health, or socioeconomic. Here you have, again, the 3 types of populations, the 6 countries, and the 2 additional ImmuHubs, and we're now on April 24, believe it or not, about to finish this endeavor. There was one important thing that we are setting ourselves as a goal, and this was, and you can see the coffee that it took to achieve these goals, and how high these goals were. So the idea was to increase by 10% the uptake of childhood and life course vaccines. Of course, because we did these low barrier interventions anonymously, we could only measure willingness to vaccinate before and after the interaction at the ImmuHub. Then 75% accuracy increase in the awareness of people's immunization status, 80% accurate understanding of the vaccination needs, which is related to that one above, 20% increase in planned consultations with health mediators and professionals, and a 20% increase in intergenerational vaccine communication. We had learned with Vivi really in previous design thinking exercises and other research that if the family talks about vaccination, the uptake usually is much better than if people take isolated decisions. So that's a really helpful peer group. So what we did work on very intensely is how can we create technology that is low barrier, easy to understand, easy to deal with. And we agreed very early on that chatbots might be the way to go. Even though Vivi had worked in the past with mobile apps, chatbots have the advantage of not requiring you to download anything on your smartphone. So you can just click on it and get started. And the natural interaction is this, having a partner that you chat with and they will ask you all the questions, a playful avatar ideally. And by the time you're finished, hopefully it wasn't too boring, you have already entered the data you need. The 3 chatbots that we developed rather than just one, again pushing the limit of what was feasible with the funding we had, was the symptom survey, the VAC app, and the health survey. You will hear much about them in the next couple of days. The VAC app is the core piece. It's really a tool to help people understand what they're vaccinated against. And then the health survey was done as an immediate response to the Ukraine crisis, when our Polish partners were receiving a lot of war refugees from Ukraine, which they are just on the other side of Lviv in Ukraine. And then the symptom survey is really to learn something from the pandemic. So these health survey, symptom survey are responses to global crises that happen in the middle of the project. The VAC app is what we were planning to do all along. So as I mentioned, the VAC app is a user-centered tool to trigger people to start looking at their vaccination record if they have one, and to try and make sense of it. Gary has written about it in the past. It has gone through many iterations. We started this in Berlin with parents waiting to be seen with their children in the waiting room. And they're sitting there for 5 hours, wiggling their thumbs, having nothing useful to do. And we had students who would approach them and say, hey, we have a fun tool here, would you like to interact with it? And many mothers told us if they had, which was only 20%, brought their vaccination record with them while bringing a child to the ER with the vaccine preventable disease, such as flu or meningitis, etc., only 20% had a vaccination record with them. That tells you something. If they did, they were invited to use playful avatars to understand that vaccination record and enter what they think they have received or their child has received through the tool. Many parents told us even then, and this is published, and we're happy to share these publications with you, told us, you know what, this is the first time I've ever looked at my kid's vaccination record. I always thought that's a thing I need to make sure I don't flush down on the toilet or lose it at home, and I'm taking it and I'm giving it back to the next doctor, but I never looked at it. So the point of this is, and I can't emphasize this enough, the point of this is if you have a dialogue on vaccination on a normal day, especially, however, in the middle of a pandemic, and I experienced that myself during the flu pandemic in the ER in Berlin. If you ask parents, is your kid vaccinated? And they just want you to stop talking about it and say yes. And then you say, well, what vaccine? They will say, well, the usual stuff. That's not vaccine action. Okay, that's vaccine passive sleeping. And if somebody gets the vaccines just to keep you quiet as a doctor, we haven't fulfilled our mission. And with the next health crisis, these people will fall away from the system. That's what we wrote already in 2011, and I think it hasn't changed. It has shown again during the COVID pandemic. If somebody is not an active participant in the immunization program to begin with, they won't become one if you throw a health crisis into the mix. They will become even more confused and less likely to engage. So the idea of the VAC app is to, yes, it is a digital vaccination record, but the idea is to activate you and pull you out of that passive recipient mode into, okay, which are the diseases that I or my child is protected from, and what are we doing next? And where am I uncertain? How can I challenge my doctor to answer my questions so that you start the dialogue from the patient side? And that's something we've learned from other interventions like hand washing. Okay, there have been a lot of studies on that topic. If you know that if a patient starts the pressure on hand washing for the physician or nurse, it works. If they say, oh, sorry, did I see you wash your hands before you touched my child? That's powerful. So I'm saying that because we're having a lot of parent representatives here. That's powerful. So if the patient or the parent approach the physician and say, well, I don't understand the vaccination record of my child. Can you help me? That's a vaccine dialogue. That's no longer top down and ignored. That's the idea of the VAC app. I went into more depth here so you can think about what we were doing at the hubs in the next couple of days. You can look at the website in more detail. This is the publication from the first iteration. You see our student interacting with a mom and a kid. The desired side effect is that some adolescent kids get tired of their moms taking too long online, and they say, let me do it, mom. That's perfectly fine. We want kids to start taking charge of their health, so that's part of the program. What we developed at the very end of the project is the web app of the back app. So in addition to a chatbot, there will be a tool where people can use this in the family context. So I can set up a proper profile that's no longer anonymous. It's probably going to be de-identified, but not completely anonymous. You can revisit your dashboard and add your family members and use it repeatedly. You can interface with your doctor. All of this is being launched now at the end of the project, as you can see on the website. You can also be a doctor who says, I want my children to be, or their families to be using this in the practice, or my adult patients, and you can invite them to use the web app to start accumulating that information for themselves. The health survey, as I mentioned before, this has a different history. It came from natural disaster situations. In my personal history, I was in the third year of being a pediatric infectious disease fellow at Tulane University in the US. And in the third year, Hurricane Katrina hit. And we had these situations of people being displaced suddenly, no medical records, no vaccination histories, no information on their health needs available. So we built a survey instrument initially on paper. This was used for migrants in Berlin in 2015-16 as a project by Vivi, and again used in response to the Ukraine crisis as a chatbot now in 20 languages. So in Berlin, we had 4 languages, now we have 20, and it's a chatbot rather than a form to be filled on a tablet, which is much more fun to do and gives more flexibility. This has also been used now. Partners have talked to me at ECMID in other conference when we spoke about this for earthquake victims in Syria and Turkey and other situations. Whenever you have a sudden displacement of a mass group of people and a stakeholder needs to know which kind of resources need to go where now, this is a very good way of getting that information from the people themselves rather than intermediaries. And during the big migration wave in 2015-16, we've seen a lot of papers published by, let's say, a tropical medicine clinic in some hospital. Well, they will see a very biased group of people. So our point here is to sort of get rid of the middlemen and get the information from the displaced people and families themselves rather than whoever happens to already access the healthcare system at some point. Yeah? And then you can read up on that on our website. And the first 4 publications that came out of the development of the Vivi Health Survey as a survey instrument, which includes education and schooling, access to housing, access to healthcare per se, disruptions of medical visits, including vaccination visits, acute symptoms, chronic symptoms, and PTSD and psychological effects of trauma. This is a very comprehensive survey where now in the chatbot, the user can pick a module that they want to talk about or that they're comfortable talking about, and then go through it rather than having to answer a long 13-page survey, which we had in the emergency rooms after Katrina initially on paper. So now the chatbot gives us the ability to adapt to people's needs. So this is already featured for many years on the IOM's health research platform. And we're very delighted to have a guest here during this, Magdalena, during this meeting, who is a representative of IOM in Poland. So the Polish team did some outstanding work in the ImmuHubs and with the health survey, and they already started collaborating with IOM on the ground in Poland. So I thought it's a wonderful gesture to have them here, and not just gesture, to hear their feedback, while this was already sort of in the health research platform, it ended up being used on the ground by their own country teams. So that's a good way of seeing where this project can go further. Last but not least, we have the Vivi Score app. That was another response to the flu pandemic. We'll talk about this later. Initially, it was supposed to be linked, just a few questions put into the Oma Olo Finnish app. That one didn't get used that much anymore after the pandemic. So we took it on ourselves and said, let's put everything we can into this Vivi Score app and make a next iteration again in all these different languages. Again, one that can interface with the doctor where people can report on disease severity subjectively and share that information with their doctor, or the doctor can score disease severity from their angle and share that with their patient. This is based on probably now 15 years of research at Vivi, many different iterations, innovation task force meetings with the European Medicines Agency, and critical path innovation meetings with the US FDA. So this thing is being taken forward as a clinical endpoint for clinical research, as a public health tool, and as a tool to bring patients and doctors closer together in their communication. The initial publication you can see here. Aya will tell you a lot about her work, and I have to say that was instrumental to learning the mood and the sentiments of people on the ground. There are many more focus groups that she's more qualified to talk about. They were done from their organization in the midst of these populations, some of them in the midst of a pandemic, some remote, some in person. So stay tuned to hear her reports on that. And I would like to mention also the symptom survey, which really didn't have extra funding in this project, but we did it anyways, because this was such an important time point. This was a result of our conversations we had almost weekly with the US FDA during the pandemic regarding the symptom score and the symptoms disease severity score that is so important, especially in children. Capturing disease severity in children with flu-like illness is very tough and needs a very rigorous scientific approach. We had that figured out. We, in collaboration with the Robert Koch Institute in Berlin, we had done 10 years of work on developing this, and now we wanted to put this forward and discuss these things with the FDA. Their idea, just so you understand where this came from, was, okay, great to have a score that doctors can do on their patients, even better if they can be children, toddlers, adults, and old people, wonderful. But we are now working on medications and vaccines that change how the patient feels, functions, and survives. They hammered these three words into my head, and I absolutely agree with them on that. If the patient doesn't feel better as a result of what we're doing, then we have failed our mission. So the question here from the FDA was, can you create a tool that will allow the patient to report the symptoms directly in a way that is scientific? So I brought this back to the Vivi think tank. This was even before the ImmuHubs project. And we said, well, how can we do this? And I'm always happy that there are social scientists in the think tank. I said, you guys look at how patients view disease severity. They went and looked, came back to me and said, there's really nothing. And I said, okay, so we need to study this question. How do people view individual symptoms of COVID, flu, RSV, all these things that are now becoming vaccine preventable, or have become already? And so that was the beginning of the symptom survey. The idea is to create a survey instrument that allows lay people to tell us what matters to them when they have a flu-like illness. Which symptom is most important? Which is less important? Which ones do they want to see prevented by vaccination? Which ones do they want to see treated? Which ones do they want to see diagnosed? And all of these things in themselves, in elderly relatives, or in their children, which may make a difference. So this is a big thing which will form the legacy also of this ImmuHubs project, because this survey now is able to keep the pulse on the time as people's attitudes towards these symptoms change from being in the middle of the pandemic to later to now, so we can keep measuring these things and integrate that knowledge into the next iterations of the Vivi Score app. That I gave you that sort of bigger Überbau, whatever you want to say here, so you remember or you get the context of why we built these different tools. So this is the symptom survey. You can pick your languages, and then this thing will start chatting with you. Milica from the Serbian team already did a nice overview of what we learned in the first iteration of this, which was a bit more nerdy on the Qualtrics. The chatbot seems to be more fun and faster. And you can look at that on the website. You can download the What We Learn section and see how we try to approach this topic and what we're trying to learn from this particular tool. So health literacy is a very important part of the ImmuHubs project, and Aya will talk about this more. She's actually writing a white paper as one of the final deliverables of the project on how to improve health literacy in the European level in a family context. And I wouldn't want to give you more theory right now. It's time to go back into practice. But remember, you can stay tuned with the ImmuHubs project, not just now, but going forward. And we have a number of social media channels: YouTube, Spotify, LinkedIn, and X, formerly Twitter. It's like the artist formerly known as Prince. We have a website, a media section there, a news section, an achievement section. You can spend your weekend there if you want, but you can also listen to the next presentations, which is maybe more likely. Thank you. Oh, there you go.
Just put myself in the most difficult position.
So Gary is our rapporteur of the External Advisory Board. We're very happy to have him here in person. We've met monthly during the second half of the project with the External Advisory Board and Hannah, and we're very happy to have you here.
Thanks, Barbara. Thank you very, very much for inviting me, for having me. It's lovely to be here. So my name is Gary Finnegan. I'm from Vaccines Today, which is an online project that's been going for almost 14 years, I think, sponsored by Vaccines Europe, and we're members of the WHO Vaccine Safety Net initiative as well. I always know we're almost 14 years because it's the same age as my eldest child, so I always she's fully vaccinated, just had her HPV jab recently. But I've been aware of some of the technologies maybe that Barbara's been working on for a few years, so when she asked me to get involved in the External Advisory Board, I was very happy to do so. I suppose the attraction of the project, because there are lots of projects, right, in this area, it's a very active area, but the reason I was happy to get involved was that it was a real on-the-ground initiative. Yeah, there's technology and there's literature review, it was very important and innovative, but this is real intervention, and as I go through this briefly, I think you realise how much has been done. I hesitate to tell you what you've done because I know many people here are the ones who did the actual work, but I hope it's interesting to hear an outside perspective on maybe where this goes from here. The other interesting thing about the whole project was that it was hard to reach groups. So you're doing this not because it was easy, but because it was difficult. No point otherwise, and because it was tailored, which is very much the direction of travel at the moment. So just to tell you what's going to happen, very briefly tell you our role and who was on the External Advisory Board, the approach we took, and then briefly our findings. There is a report which is only about 15 pages and has a 2-page summary at the top because we wanted people to read it. And I hope some of you will take a look at this and maybe take it forward, and some of the agencies and other partners might also take a look. So what our role was, so really it was to engage with the project coordinators, and we also spoke to some work package leaders during the course of this work, and then to evaluate the impact and sustainability, so the what happens next, which I think Paola and Barbara also said was really important at this point of the process. And then to produce a report that's complementary to the big report that has to be filed. We're not the evaluation work package. We are the external group, and we're reflecting on how this fits into what else is happening and into what might have potential for future projects and future initiatives. So the other attraction maybe for me joining this group was that it was a diverse group, and indeed the whole project is one of the great strengths is that it includes parents and patients. Here, health professionals like Naveen, who incidentally is a social media guru. He's unbelievable on the communication side, which also is very interesting because in this project there were some innovative approaches to dissemination too. And of course, Mohammed and Siddhartha gave an institutional view, zoomed out from the European and Eastern Mediterranean perspectives, and I was good at taking notes. I guess that's what I would do. So our approach, we began at the beginning, of course, maybe even before 2022, but our real work I feel, began around this time last year, and we started having meetings last June online every month, just to catch up, and then we began inviting work package leaders to come as guests and present the state of play. It was difficult, of course, for us to begin talking about our report until we were quite close to the end. So the real action happened earlier this year. In fact, I think we drafted the first chapter last December just to get things moving, but yeah, it all sort of comes together really quickly at the end, as these things always have to do. So briefly, as I say, I don't want to overlap with the report that exists, and I don't want to repeat what Barbara has said, but some of the positives of the report, of course, the technology, some of which was developed from existing tools, and others came more so during the project, translated into 20 languages, which of course is really key. As I said at the beginning, targeting marginalized groups that are traditionally hard to reach. On the communication side, as Barbara said, there was social media campaigns, but also the podcast series, which is now a repository of material that exists and can be used for educational or other reasons if you want to learn about a specific marginalized group, or even to take the approach and apply it to a group that wasn't included here. The inclusion of a really broad mix of stakeholders, I think, is one of the great strengths and something to take forward into future projects. A wide range of civil society actors, patients, parents, and so on, which I think is crucial. And as I'll say again later, will be difficult if everyone wants to do it. We need to upskill and train some of the NGOs and the social bodies that are out there. But I think they proved of great value in this initiative. So just as I said, the report is out there, about 15 pages. I hope some of you will take a look at it. But summarizing that summary, if I can do that, as Barbara said, this project was conceived in a different era, right? Like it was pre-COVID and everything. So I think one of the challenges, but also something that showed great flexibility in the coordinators, was dealing with two of the biggest crises in our lifetimes, which were the pandemic and the invasion of Ukraine. So this led to some expansion of the project, some adaptation, in some cases changing target groups, and required a lot of goodwill from partners and adaptability right across the group. So it wouldn't have worked otherwise. On the dissemination side, which is an area where I have some familiarity, at least, I know that vaccine communication is a noisy space. It's very difficult to break through and be heard. And here, the podcast series I thought was particularly commendable. This is the type of thing, looking ahead, that could be expanded with budget or with a different project. But again, I was always glad to see an active dissemination and communication work package. Sometimes this is included because it's required, but it's not always quite so dynamic, but this was a good one. I hesitate to evaluate the evaluation work package other than to say it was very well done, right? Of course, the setup was the difficult part. Once they got up and running, evaluation was more feasible. Some had found it easier than others to get going and to get people to engage with the tools and so on. Getting feedback from people, in self-evaluation can be difficult and took a lot of chasing, I feel, from the people running this package, but they did it bravely all the same. I suppose in terms of allowing for self-evaluation, I think this was a necessary and reasonable, compromise. You could go and visit every hub, but the budget for this was very modest, and I think self-evaluation was a good choice, and allowed for 20 hubs to do their thing and report for themselves. COVID was included in this work package afterwards. That's just the way it goes. No one foresaw this event. If the timing had been different, maybe it could have been its own work package. But this was a pragmatic choice. For the ImmuHubs, so this is the real world stuff. As I said at the start, the real value of the project is that these were chosen because they were difficult. So the challenges were a feature, not a bug. Doing things that are easy is no fun anyway. And of course, there was flexibility shown along the way. In Poland, they shifted from the Jehovah's Witness target to accommodate war refugees. There was also, I think, similarly in Finland, the Swedish naturalists increased their vaccination, right, because they had a measles outbreak. But anyway, so this was changed, I think, to older people in Finland who were born outside Finland. So again, flexibility right across the board in all work packages. The impact on changing literacy attitudes and confidence, I think, gives us some optimism for expecting this to be something that could be tried in other venues with other groups. And as I said, the most difficult thing with setting up a hub is setting up the hub. Once it's there, continuing it is easier than the beginning, and this could be applied to other hard-to-reach groups. Throughout the project, all the tools, the technology, the apps were reviewed, and new iterations came to make them more user-friendly with the chatbots and so on. Again, I don't want to repeat what has been said here already, but the symptom survey was reviewed. The literature review was the first of its kind, and revealed a real limitation of high-quality studies, I think, in this field. Focus groups, I must say, I thought was really useful, but I have the impression it was quite time-consuming and challenging to recruit people, probably just because of vaccine fatigue. By the time you're rolling this out, everyone knows that the world is quite tired of hearing about vaccines these days, so convincing people to sit down for a prolonged period is challenging, and indeed for a short period to engage with some of the apps. The technology is one of the big legacies, I think, for the project. At the beginning of the project, this was like the pre-ChatGPT era, so I'm sure if we were moving to a new project, people would be looking at how to develop these tools with those large language models in mind, chatbots. It's been a long time in chatbot development, basically, over this couple of years. As Barbara's explained, some of the tools are already proven their use in different situations for mobile immunization records, for example, for mobile populations. The integration, as was said, into the Finnish app wasn't feasible during the project, but this is, I think, natural in a project that runs over several years. The variety of tools looks like a lot from the outside, I thought sometimes, and I bet on the inside it also looked like quite a few tools. For people arriving, there is potential for overwhelming the participants, and maybe even some of those delivering the project. So anyway, that's because I say this because at the beginning I was, which is the survey patient? Yeah, there was quite a few. So. That notwithstanding, I think the apps and those digital tools will be one of the big legacies. So in the end, this wasn't a desk research project. It wasn't a single site intervention. It's not something that's easily done. These were real world hubs in 20 different places with difficult to reach groups. The diverse network that was brought together at the beginning was really useful for ensuring its impact, for getting the message out to those marginalized groups. And I think these networks of advocates, even after a project, survive, right, just for human reasons, because people have relationships like this, and that these networks of advocates in the vaccine space are a feature of a resilient health system, which is like a real buzzword now, but they are. These things last even after the project ends. So I think this tailored approach, which existed, the WHO TIPS has this. This is one of the kind of the Bible on this for a few years. But this tailored initiative in action was good to see. The apps have real potential for further development and use. The podcast series, I think, was great, and certainly has great potential to be even better as an educational and even general engagement resource. There's a few of these happening now. WHO Europe has one on health in general. Coalition for Life Course Immunization has one starting tomorrow, and so this is a space that people are using all the time, and it's something to build on. The civil society actors, I keep repeating, are really important in multiplying messages and keeping them together. We should all do it, but we need to train people to engage, let them know that these things exist, train them, and somehow resource them. Could mean somehow pay them. I don't know. It's a very complicated thing, but we can't just ask the same relatively small network of NGOs and civil society people to come join every project. Or we need to expand these patient groups so they have the capacity to do it. But they do add value, so this is something that's worth keeping in mind for future initiatives. The very last conclusion one, it was good value. I forgot regularly how much the budget was for this. Every so often.
So did we.
Yeah, so did you. Yes, I suspect that. Yeah. So some of the challenges that arose were just the fault of enthusiasm outstripping funding, right? I look sometimes at big horizon projects. I know it's different. That's research and so on. Big IMI or IHI projects as they are now, enormous. This was less than €1 million. And the scope of it is enormous. So I think the successes are a testament to the commitment of the project leaders and to all the partners who delivered this thing in the wild, in the real world. So on that, congratulations, and thanks a lot for inviting me to be involved.
Thank you all. Is there any questions for Gary?
That's
What now or during the coffee break? Please come in the coffee break. No, not physical.
Yeah, maybe questions.
So Sabina, yeah, we're very pleased to have Sabina here at the Conference correctly. She's leading here at Vaccines Europe, and I think it's going to be phenomenal to hear her perspective on all the things we've been doing over the years. Thank you, Sabina.
Okay. How does that work?
I will have to get the bottom. So is the one was
This is one. So thank you very much, and good afternoon, everybody. Thank you, Barbara, for inviting me. I don't know if you all know what is Vaccines Europe. And so Vaccines Europe is a trade association. We are here based in Brussels. We represent the vaccine industry. And so I represent 14 member companies here. So I'm voicing the voice of the vaccine industry. And what we are doing, well, we are ensuring that research, development, and manufacturing will keep happening here in Europe, ensuring that the regulatory environment is streamlined and ensure fast access to innovative vaccines for the population. And we are also keep raising the importance of vaccines, of vaccination, and the value of vaccines and vaccination to all policymakers who have temptation of forgetting about it very quickly. And interestingly enough, you talk about COVID-19, I mean, people have forgotten about COVID-19 already somehow, and the burden that it created to the society, to the economy, and the return that we actually got from fast access to innovative vaccines. So our role is to keep the vaccine and vaccination high on the political agenda to ensure that the policymakers keep that in their radar. But beyond the radar is, I mean, for us, our aim would be to ensure that they see the importance, the value of immunization or vaccination immunization as an important primary preventative tool where they need to invest rather than seeing this as a cost. And when I say invest, and I should have said I'm a health economist by background, so a lot of economists here, but you need that to fund, to ensure that the programs are appropriately supported. We see there is a lot of issues, but then funding and ensuring that you have the budget dedicated to that is absolutely critical. So that's what we do. It keeps us fairly busy. On the vaccines confidence side, we
or somehow involved, but we try to have a step back, and this is why Vaccines Today is for. It's not directed by us, it is just funded by us, and Gary can testimony, I'm not interfering with their agenda, and I don't need to do that. We are much more triggering our policymakers with regards to what I just mentioned. So why do we need an EU immunization strategy? Just to position a little bit the context, you know that we were going to go through EU election in June this year. We are going to get a new parliament, new commission, and our work is to re-educate all of those new people that will be in charge of the policies for the next 5 years. So as many organizations, what you do when you have an EU election, or election even at national level, but we have manifestos, we are actually putting together what we are hoping to gain from the next mandate. And here our call is to ensure that we have a European immunization strategy. So we kind of continue leverage where the Commission has started to initiate, and I will discuss a little bit about that, but rather ensure sustainability and beyond that. So I'm not going to go on these slides to convince you about the value of vaccination. Clearly, this is not you that I need to convince, but this is what I want to say is clearly what we need to do, is ensuring that people keep in mind, keeping their in the focal point that immunization is a powerful tool to prevent sickness, save lives, save money, and contribute to strong growth and strong communities. I mean, we talked about resiliency. It's a buzzword, but it's actually the word that actually expresses very, very well the contribution of vaccination in ensuring the resiliency of the healthcare system, of the society, and the economy. And that's clear. But it needs to be said fairly strongly, without a shame, without anything, in ensuring that all policymakers understand that very clearly. Vaccination brings, so what is really, really at stake right now is that vaccination is seen kind of as really important public health tools, no issue about that. But when we see the implementation of the program, the issues that you actually face during the project, the fact that we are right now in the middle of an outbreak of measles and pertussis here in Europe, that we have issues of uptake on many of our vaccines beyond pediatrics as well, we just have a problem of funding of our immunization programs. Yesterday, we were at Vaccinopolis in Antwerp with Professor Van Dam, and we hosted an event on the data-driven life course immunization. What are we waiting for? And clearly, the whole point here was, well, if you want to have high uptake, we need to have data. We need to see where things are at in terms of coverage rates for all our vaccines as part of our national immunization programs. And with the data, we can see whether we are below the targets of the coverage rates, such as measles. We can anticipate outbreaks. We know which type of communities are not well covered, and then have the right policy approach in order to protect them. But despite that, I mean, most of the European countries right now do not have electronic immunization registries. So we have no clue where we are at. And when I see communication related to the measles outbreak, saying, oh my God, we have measles outbreak, despite availability of efficacious vaccines, efficacious and safe vaccines, then, well, what did you expect? You just don't know where the coverage rates are at with most of your member states. So yes, but we could anticipate all of that. And we need to invest. We need to invest in the infrastructure. We need to invest in data registries in order to have this happening. But today, healthcare, and immunization is part of that, is seen as a cost, not as an investment. And because it is seen as a cost, there is no willingness to invest much more in the immunization programs. And it is our role to bring data in a different way to demonstrate that actually investing in immunization is not a cost, it's rather a capital investment meaning that you bring a strong community, you growth to your economy, and you get return to your investment. So this is work that we do. The data that you have on these slides are fairly old, I must say, as they are pre-COVID-19. But the point is, it's different from a cost-effectiveness traditional type of analysis where you say, if you invest in these vaccines, you're going to save that much for the healthcare system, which is the argument of the Ministry of Health, for example. Here we bring a different type of data, of information, where we say, actually, if you prevent infectious diseases across the lifespan of an individual, 80 years of life, and you take the assumption that this individual receive all the vaccines he is eligible to receive based on the national immunization programs, that would cost for this individual just about 3,000, I would round it up for 4,000 euros, let's say. So 80 years of life, prevention of about 20 infectious diseases today, if we follow national immunization programs, 4,000 euros is less than 2 iPads. So it's a kind of thinking that, oh, is it really expensive to protect the population? Maybe something to reflect on. And then if you take a different approach as well in terms of return on investment, you can look at a fiscal approach. How much contribution in terms of tax do we get from a protected population? And there was this study which is really fiscal oriented, so tax. So we look really at the income tax here. Which looked at, by vaccinating the older adult population, or older, not completely older, but 50 plus, I would say, population. I'm nearly 50, so if you invest €1 in this population, preventing influenza, herpes zoster, pneumococcal, etc., how much you get back? You get actually €4 back. So whatever you do, it's a gain in money rather than a cost. So maybe there is something to shift in the mindset of our policymakers. And maybe the Ministry of Health, who is dependent on his Ministry of Economy and Ministry of Finance, do not have the right data to defend this budget. So neither the right arguments. I'm sharing this new report, which was published last week, the socio-economic value of adult immunization programs, which was done by the Office of Health Economics, commissioned by IFPMA. IFPMA is basically the equivalent at global level, the International Federation of the Pharmaceutical Industry, based in Geneva. And what they've done a massive literature review on the value of adult immunization, focusing on 4 vaccines: influenza, pneumococcal, RSV, and herpes zoster, across 10 countries. So different countries in terms of wealth, I would say, and social values. But out of those 10 countries, we have Latin America, for example, but we also have 4 European countries: France, Germany, Italy, and Poland. And the main message here is, whatever you look at in terms of countries, overall, any dollar invested in adult immunization, you get $19 back. And the message here is the return on social economic benefits that you get from vaccination, which is different from the tax fiscal approach that I presented before. So that's where the difference in numbers are coming from. And they are actually complementary, because one is really, I would say, a kind of gross type of data. This is in terms of tax, what you get back. Here is, if you take into consideration the broad value of vaccination, so not only on the healthcare system, but what you gain in with a healthy population, a population that contribute, that is productive, contribute to the system, but consume as well, but also take care, parents that take care of their children, they don't have to induce sick leave, etc. How much this actually comes back to the society, and this is what this number represents. And the message here is, and for per person, is actually over $4,000 per person in terms of return. So it is huge, and it is a different message. Whatever you do, For each single euros, I would convert to euros, we put into adult immunization, it's a positive return that you would get. So it's not a cost, it's actually a capital expenditure, meaning that you invest, you get a return. And why this is really important to raise right now, and I did it, I said it yesterday where I was intervening. I said, I don't want to be alarmist, but I think we need to be alarmist because there is a lot of challenges that we have to face right now. And if our government do not switch their mindset towards more prevention and investing more in prevention, this is going to be super complex. Despite the existence of HERA, despite the existence of national preparedness plans. I think this is really important to mention. We have strong economic pressure as a consequence of the pandemic, and this is really specific to the EU. No, it's not the same thing everywhere, but strong economic pressure. When you have economic pressure, what is the consequence? You have budget cuts. When you have budget cuts, which is the first budget cut? Who wants to reply? Health. The Commission recently communicated education is the second one on the row. The European Commission recently cut €1 billion in its budget dedicated to health. And this is a reality. And this is not going to happen. We know that when you start cutting your health budget, it's going to be a domino effect on the wealthiness of your population too. We have geopolitical tensions, and all those challenges, actually, I should have said it, those challenges that we need to face, they're all actually prone to increase the burden of infectious diseases, and especially on the adult part. So I think it's really important to take this into consideration. The geopolitical tensions we are here, we are in right now. I mean, started 2 years ago with the war in Ukraine. We see from the news it's not going to get better. And we know that those geopolitical tensions brings a lot of complexity and complications that we have to deal with. Climate change is going to come with this lot of new infectious diseases that we have to take care of. The rise of antimicrobial resistance. I mentioned this one. We were on the 14th of February was the launch of the second joint action on AMR. And we've been invited kind of last minute as a stakeholder forum participant. And I was struck saying that, to see that human vaccination has not been considered. You have everything in it, and it's great, but among the holistic approach, which is meant to be a One Health approach, human vaccination and the role of human vaccination against or in the fight against AMR is not there at all. And when I raise the question, I say, it's an afterthought. What? But you have animal vaccination, all good. So that's something to also consider. The aging of the population. I mean, you know what this means for older adults. Immunosenescence, underlying conditions with cardiovascular disease, diabetes, etc., cancer. But it also means that you will have, and you already have, a shrinkage of your healthcare workforce and less people to take care of the patient population. So we need to protect our systems too. The first line of protection is prevention. Declining science literacy and trust in the institutions. We see what will be the outcome of the election, but I think it's going to continue reflecting that. And one challenge that is not here, I should put it here actually, but I mentioned already, is a low investment in the immunization programs. So 0.5% of the healthcare budget dedicated to immunization is clearly not enough to face the issues that we have today, the rise of vaccine hesitancy, the outbreaks, etc. But all those challenges on the slides that we will have to face too. So we need to do something. We need to ensure that immunization remains on the political agenda. That's really critical. And it is really at the heart of what needs to be done to build a resilient and sustainable health system, but also economy, societies, communities. Here is an interesting report, high-level, high-policy, EU policy report. Right now, the Commission is very into assessing what we can do to increase EU competitiveness compared to the rise of China, the protectionism that is happening in the US, and how to actually ensure that Europe remain competitive in a very difficult, I would say, global environment. And as part of that, the European Commission have commissioned 2 reports, one on the value of the single market, the single EU market, which has been done by Enrico Letta, former Prime Minister of Italy, and the second one that is on its way, which is really focusing on the EU competitiveness itself, by Mario Draghi, also another Italian, former Italian Prime Minister. The report from Enrico Letta, so is about 20 even more pages, published last week, has an interesting session dedicated to health care resiliency. And as part of that, and I will just highlight it, well, AMR is clearly stated there, but what is important is what is in the middle, so I just read it. Alongside policies supporting new antibiotic research, combating resistance, we must prioritize the vaccination of Europeans as a critical tool for preventing viruses and diseases, especially among frail patients, children, and the elderly. Implementing a European vaccines passport is increasingly urgent. I think this is a very great mention. I mean, it could have been phrased better potentially, but I think to see that in such a high-level policy report is encouraging because it will influence what the next Commission would do potentially if we keep the same president. And the aging population and the fiscal pressure that is going to create is also mentioned. So it's all that to say that what I'm telling is resonating, but is linked to our current environment. So with regards to how the EU is actually engaged on the topic of immunization, I must say that this mandate, I've seen actually the European Commission so engaged on vaccination and immunization. I mean, over the mandate, which actually really leverage the outcome of the previous mandate, they have done a lot. We had a European vaccination roadmap with a lot of initiatives. They have launched many programs, many I would say, funded programs to support immunization. ImmuHubs is part of that. So a lot has been done. So it is seen on 2018, the Council recommendation to strengthen vaccines preventable disease. The 18-22, we have the vaccination roadmap. We had a Council conclusion on vaccination during the Czech presidency. And we just have the recommendation on vaccines preventable cancer that will be normally voted in June. So a lot of positive things here. The issue that we actually see is the sustainability of the initiatives taken with us. As part of the Council conclusion, as the roadmap, one big initiative was to have the Vaccines Confidence Project run by the London School of Hygiene and Tropical Medicine, for example, which every 2 years meant to assess the level of vaccines confidence across the 27 member states. Well, this initiative is not going to be sustained because the European Commission has decided not to fund it anymore. Well, this is really a problem because we were discussing, we know from the latest report that the most hesitant part of the population right now is the young adults, 18, 34 years of age, which are the young parents, the future generation of young parents. And that helps a lot the member states to have the right policy actions potentially to take on. In the absence of such evidence, of such data, you can't do anything anymore. We have seen other, in a pan-European way. So having really this pan-European approach, I see you, Barbara, saying, in the sense where we have a cohesive way of gathering the information and the data, of analyzing it, pan-European wise, so 27 member states, not a cluster of countries across the region. And we stopped that. It delivered, it demonstrated its value, and we stopped it. And if it's not the Commission to fund a pan-European initiative like that, who it is? And this is really, and issues like this, we've seen it happening on many, many other projects. We've seen it with IMI, IHI, for example, for public-private partnership in research. We see it in other stands. So our concern is really this notion of sustainability. What we see is also initiatives being done, new projects being done on things that has been done already. And then it's, why are we always reinventing the wheel? So superb initiative like this project, like your project, like ImmuHub, that delivers on amazing tools and outcomes, how to ensure the sustainability, the scale up of it beyond actually the initial project. So this is why, and this is just to wrap up, when we put our manifesto forward, and what we have been working over the last year to engage our policymakers is to ensure that we keep having an innovative Europe. So here is really about forward-thinking policies to ensure that innovation is kept happening in Europe, that the regulatory environment is also smooth for the arrival of new vaccines, the access environment as well, fit for purpose for innovative vaccines, a healthy Europe. So here our main call is to monitor the life course immunization targets. So ensuring that first we have targets defined for the different vaccines and not only for flu or measles, but having proper targets, because when we have the targets, we know where to go. But if you have targets, you need to monitor them, so you need to have the tools to assess. And the prosperous Europe, because if you have a healthy population, you have a prosperous region. And we call here the EU to actually set appropriate financial targets to support the immunization programs and to invest in the immunization program. So it's a strong call here. And we hope that throughout the election process that is going to happen in June, we will manage to ensure that immunization remains on the agenda. Thank you. Happy to take questions.
Thank you. It's very comprehensive. I can see problem questions.
So thank you very much for all the work you're doing and your presence here today. It's the first time I hear that the project by Larson is not going to be funded for the on vaccine testing. And my question is this has to do with Brexit or?
No, it's not to do with Brexit at all. When we try to discuss, it's not I'll say discuss, but exchange, I would say, with the Commission on that. They said, well, we've done what we were supposed to do as part of the roadmap. And today, our investment in immunization or vaccination is on cancer. So they had their mission cancer, the European Beating Cancer Plan. As part of that, we have been instrumental in ensuring that hepatitis B and HPV will be part of that. So the council recommendation we are waiting for in June for vaccines preventable cancers. So fairly strong, and we are pleased with that, I must say. But they wanted to focus only on that. And when you talk to them today, they say, well, our focus is on cancer. So we won't do anything else or invest in anything else. We just want to, and you should be happy, immunization is part of it. But that's it. The vaccines preventable cancer conclusion was really interesting because they put a stance that can be leveraged through other vaccines. So there's something that can be worked through here. But this is in terms of priorities and budget allocations, this is their decision, and I haven't been able to change that. So this is also why there's a big push to say you need to go beyond that. You need to have I would say, a holistic approach to immunization.
Has it been spoken to them that cancer patients undergoing chemotherapy are specifically sensitive to certain diseases?
Yeah, but
I mean, it's so short-sighted, it's these labels that come, so I think one thing to learn is how to put vaccines on top of the agenda with all these topics, as we discussed before, modeling the impact of vaccines on AMR is highly complex, but extremely important. We've shown this in short one hospital circumstances, we can expand on that. And so I think it just needs to be this six and center, vaccines are important for one health and important for cancer patients who survived surgery, chemotherapy, very expensive investments. In my experience as an infectious disease physician, the biggest challenge post-cancer is an infectious disease that will take somebody's life. And most of these are now vaccine preventable. So there is this policymakers tend to use these topic words. I understand that comes from the idea of being focused with investments. But at the same time, if you don't do that comprehensively, you lose your investment. That's sort of what I would argue there. And hearing your review as an economist to me is extremely important because there are two reasons for it. One is when I was working on these policy briefing notes, I always felt like I was looking for literature that would support what you intuitively know as a clinician or even as a person is true. Right? So you look for the data that can show model these complex things. What happens if somebody has zoster and drops out of work for a month? That must cost money. How much does the zoster vaccine? But it seems common sense, but it's hard to put on paper, and I think you need more of that to then feed it back to policymakers. And the other part of me is the one that is being German, the idea of dies and flies has been very problematic to convince a German policymaker because of our very sad history. And the idea of assigning monetary value to somebody's life is something that makes most people in our country now cringe for good reasons. So I think the fixation on that was not a long-term thought. That, as you said, there was a long period of looking for that in publications and focusing on that. It's very problematic because you can challenge the basic proposition of it. Thinking about the global lifespan of somebody, I find that much more fruitful, and it should include childhood vaccines too, because if somebody dies or becomes handicapped in the 5th year of life, that will also impact the economy for sure, because you don't have that person later in the workforce. So I find that extremely encouraging. I think there should be more collaborations between people who work on these economic, highly complex data and who are able to communicate them, such as yourself. People who develop tools that can create the data from the source. So some of these data that come out of that, or come out of the symptom survey, or come out of the score app in the future, they will give information how to underpin these economic studies with actual scientific data. I think that's something that may be needed for the next European Parliament and cycle in order to be vocal here in Brussels and nationally. And with the lender, which are hosting us here for lending. And so even in Germany, the mandate, for example, is on health is with the lender, the federal state government and state government. So that is also the blessing of federalism in good and bad ways. So we have to know we have all these levels and make sure this.
It is critical, and if I can piggyback what you were talking, Barbara, it makes me think is when I started as a younger, long time ago, as a health economist, so I was doing models for companies I was working for on the cost-effectiveness analysis of rotavirus vaccines, etc. And my only reference were actually guidelines for treatment. Mm-hmm. And that's the issue, is that everything that was actually used, but we reshape that, is leveraging things that were done for treatment, not for prevention. During the whole work that happens for the new general pharmaceutical legislation that maybe some of you may be aware of, there was a lot about unmet medical need. I can tell you that prevention was not part of that. So it was our job to position actually the value of prevention and vaccination to meet unmet medical need, to prevent anything that could happen, and how you position that properly, because people do not think about it. And there was no voice until now to really push for it in the value of prevention. But AMR is the same story. When you think about AMR, you think about antibiotics. We need to have this raising, I would say, the voice, there's a community really raising about, well, actually, prevention, vaccination is a different animal. You cannot not think about it, but you cannot think that every tools are fit for purpose. You need to adapt completely your tools. They are valid, but you need to adapt for the specificities of the vaccines. And I think this is super important. And raising that in a broader sense, we have to be very local, unified ourselves, and the collaboration is critical here because we are a minority compared to the rest of diabetes, cardiovascular disease, rare disease, etc. We are tiny like this. So it's just by working all together, collaborating together, and passing those messages that we will succeed.
How about the position of health insurance companies? I mean, they must see the immediate benefit of vaccination. Right? I mean, they're pretty aware. So it's also they have data. Are they sharing those for analysis like what you're doing?
Well, I don't know because this is at national level, so we need to see. Yeah.
Because mine changed its name from Krankenkasse to Gesundheitskasse. Krankenkasse was the name Bismarck gave in 1870, and now it's called the health insurance. Like in English, it's a health insurance. In German, it used to be illness insurance. So if they think this way, maybe they have a thought left over for us for prevention. Okay, yes.
I'm not sure.
Thank you. Thank you so much for your contribution.
Oh, thank you.
We do have a break until it's not a little bit to half an hour, but service cells. When do we meet again? 3 o'clock.
So my name is Vana Papaevangelou, and I'm here as a representative of EAP, which was the lead for WP4, for the Work Package 4. So my task today is just to make a very short introduction to set the scene for the next session, which is going to be the panel discussion. So I'm just going to, warm up the discussion, nothing more than that. So today I'm going to just remind everyone who we are and what the aims, although Barbara already said that, so I'm going to go fast. And I'm going to try to describe very briefly, using my view of what happened, how the ImmuHubs were set, and how we use the analog tool, the VACAP tool, and the health survey. And I'm going to conclude with a slide with lessons learned and next steps. So I think that already we've all discussed the 6 countries, and you can see here the picture of the coordinators: Hanna for Finland, Artur for Poland, Adamos for Cyprus, Kaja for Serbia, Maria for Greece, and Anna for Portugal. So basically our task was to try and identify and close the immunization gap in the society. And to do that, as already said, we didn't take the easy way. We focused on the difficult to reach and under-vaccinated populations in EU, and our aim was to increase vaccination through increase of health literacy. And so each country had to set up the 3 target population immune hubs. And as Barbara already alluded to, the 3 groups shown here in the 3 columns included the disenfranchised populations, which were against or away from good vaccination coverage, mainly due to socioeconomic reasons, the isolated and closed communities that had cultural barriers to get vaccinated, and finally the ethnic and cross-border populations that for geographic regions were under-vaccinated. Plus the 2 groups in Greece, people living with HIV/AIDS and viral hepatitis, and children with asthma in Portugal. So Praxis was a very important coordinator and partner in trying to set the ImmuHubs and partnering with the communities. So for each community, the task was to try and identify the leader, the person who was the key person in this closed community to help us reach out to the population. And the Praxis initiative included very important podcasts that were aiming to promote engagement, and they were disseminated both through the website of ImmuHubs, but also through significant social media channels. And as already mentioned, at the same time, there were also invitation flyers available and distributed in 20 languages, which is significant. So just to see the outcome of this, I have this pie here, which shows the engagement, what brought people into the ImmuHubs on the ground. And you can see that, of course, the website was important, the leaflets were important, social media a little less, but the big effort was the largest amount of people came because of the word of mouth. So we really, I think, succeeded in bringing up the discussion, starting the discussion on vaccination and the importance of vaccination coverage. And I think that this should be mentioned as a success. Just a snapshot of the participants in the 6 countries and their contributions. Portugal is the queen in our group, and here you can see all the 20 different hubs and the people that were successfully enrolled in this ImmuHubs. And you can see that we reached almost 1,500 people, mainly women and young, with a mean age of 31 years old. So, as Barbara already mentioned, the first thing that was handed out to these people was the analog tool, and this would give them explain, of course, the whole process and the aims, and also the methodology of their visit. And first, they were asked questions on how they use digital tools in real life when they want to find information for their health. So questions, like, is internet helpful, and do you trust information found in the internet? And these kind of questions were asked to the participants. And most importantly, they were also asked to estimate their digital literacy. How do you want to use the most important tool that we have, the VAC app? Do you want to do that on your own smartphone and have full control? Do you want to use the tablet that is available in the ImmuHub, or do you just want to have an interview with some personnel of the ImmuHub because you don't feel like using a digital tool? And of course, they were also asked if they want to opt out at that point. And you can see that there are noticeable differences. I'm just going to show you a couple of examples. Here from Poland, for example, you can see that the young and unaccompanied minors, the young population, were the ones that really wanted to look into the internet to find, to answer questions about their own health. And on the right hand, you can see that more than 50% of the participants in the Polish ImmuHubs wanted to use their own smartphones. On the other hand, in Greece, although seasonal workers and first generation and second generation migrants wanted to use, were trusting internet to find solutions for the health issues, you can see that the Roma population showed here in orange were all over the place, so very inconsistent answers. But overall, if we look at the total of the ImmuHubs participants, almost 1,500, you can see that the bars are skewed on the right hand. So people were trustful of the head of the internet. This is the answer to I know where to find helpful health resources in the internet, and I know how to use health information in the internet. So our impression is that our population enrolled had a rather good level of digital literacy and healthy digital literacy to use for their health questions. So the most important, the core application that we have been using on the ground was the VAC app, as already said. And I just want to use this opportunity to give you 2 or 3 slides of the results of our results. So I found most impressive this slide. As you all remember or know, this vaccination, and it consisted of certain same pre and post questions to see how their activity during the visit in the ImmuHub changed their views and their beliefs on vaccination. on this single visit, and also they were asked questions on specific vaccinations. So looking at the pre-post vaccination answers to questions, you can see here the answer to the question, what is your vaccination status? And I think that this is really impressive because before, when they first entered the ImmuHub, a big proportion of the enrolled population claimed that they knew they were fully vaccinated and they knew their vaccination status. And after discussing for a few hours on vaccination, their trust to they know the status of vaccination decreased, which means that we succeeded in raising the question and the need for them to go and look further and identify if there are missed opportunities of vaccination and whether they need to get further vaccines to be fully vaccinated. And also, this is a very impressive slide because it shows how the VACAP indeed engaged people, and the participants were more so likely to start discussing and answering questions. So to the question, do you plan to vaccinate yourself according to the official vaccination schedule, during the pre-VAC questionnaire, very few answers. Most did not want to answer to this question. They didn't know how to answer to this question. And then after the end of this one visit at the ImmuHub, they start being open and talking about it. And it's fine. They say, I don't know. They say, no, I don't want to get vaccinated. But still, we have commenced a conversation. And this is really very important. I don't want to be taking much of the time because I think the panel discussion is where most of the results are going to be discussed. To assess the knowledge about the vaccination, we used the green light system. So if they knew they were vaccinated for tetanus, they would say yes, and it was a green light. If they weren't sure, it was an orange. If they knew they have not been vaccinated, it was a red. And of course, most green bars, the highest green bars, are for the basic vaccines of tetanus, polio, measles, and hepatitis B. Those were the ones that were the new that had been vaccinated. As Barbara mentioned, after completing the VACAP, they were given the opportunity to also answer some other questions, to take part of another digital tool and try and identify problems or challenges or problems or challenges that they have with other issues of their health. And I'm going to just give you a snapshot of a couple of other results we have. So you can see that not all of them responded to the health survey. It was not obligatory, of course. So the big blue pies here show that this was healthy population. They had not missed any doctor visit, and they did not actually have any doctor visit during the their stay in the new after they began migration. They did not report pain. They did not report accidents or violence. On the questionnaire on immunizations, what is important, as Barbara already mentioned, only a third of them had a vaccine card. Half of them did not know if they ever had. Another third of them did not even know if they ever had a vaccination card, and a third of them knew that they had in the country of origin but had forgotten it there or had misplaced it. And the big red here bar represents the people that were against vaccination. So this really means and shows how much work needs more to be done. These are populations that are vaccine hesitant, and there is more need for more work. And finally, when we asked them about chronic conditions, you can see that 95% had no chronic conditions. Women, young women with no chronic problems. So I'm just going to conclude with lessons learned and thoughts for next steps. So the innovation and technology were central to this project. Using anonymous and innovative digital tools during a single interaction with participants was very essential to build trust and have people come in and enroll in this project. The participants felt safe because there was no way that they could be identified. But on the other hand, we missed something. We didn't have the opportunity, and budget-wise, but also as we planned, we didn't have the opportunity to bring them back for a second or third time and look at long-term effects, which is a negative thing that we need to discuss for our future projects. And besides that, though, there was an impact even from a single visit. And I think that everybody talked about the strengths. I'm going to just finish by saying about the lessons learned. Digital tools enable sustainability because they're still there on the website, and other groups after this is all done, have the availability of looking what can be achieved and go forward. And we need, I think, to think on our next steps, how we could have a more continuous engagement of these populations in order to have a longer term effects. And with that, I would like to thank you more for your for being as a group all together all this time, and less for your attention today.
I know that we're kind of late with our time. Thanks a lot, Vanna. But if there are any burning questions to Vanna, let's take them now before we climb up here for the panel.
I just had one remark.
Yeah.
What I thought was interesting on the health survey, was.
Do we take the mic so that those online, which are about 65 or so, that can also hear?
Okay, cool. So we can use this also in the panel discussion. That may be useful to have a mic there. Thank you so much, Vanna. It was a tour de force, very fast, but there will be very good data coming out of this project. I'm very hopeful for everybody. We're inviting anyone who likes to collaborate with us to learn these lessons into the long term. I fully believe the assessment. What I found interesting personally, so the health service was administered at the hubs, but also independently at the hubs, with just sending out lists, etc. What I found interesting personally is that the past two iterations of the health service, after Hurricane Katrina in New Orleans, which was really adolescents and then mothers usually bringing them there, but the adolescents are youth answering. The second time, it was really young, mostly male adults who have migrated to Germany with this big wave of immigration in 2015-16. They were late adolescents, early adulthood. And now we're talking about mothers with children, which is a completely different group. And I think for everyone here, and also make mothers smart and all this, it would be very interesting to see how their answers differ from the answers we have received in the past, and to do some comparative analysis with the already published and on the IOM website amplified publications from past iterations. There's so much work to be done, and so much data analysis will be very interesting. Thank you.
Thanks a lot. If there is no further burning questions, then may I invite 6 people here on the stage. That is Adamos Hadjipanais from Cyprus, and Yona Tabaki from Greece, and Adam Sidor from Poland, and Anna Neves from Portugal, and Kaya Damjanovic from Serbia, and Kalpana Bastola from Finland.
Sorry.
Can we take that down? Or?
Okay.
So how many mics do we have?
So,
And the is this working? Yeah. Okay. So the idea is that we discuss here and hear from the panelists on your hands-on experience, your goods and your bads, and maybe also your lessons on what we have learned so far. And if somebody is going to launch something similar, then how should they do it? We have about a good half an hour for this, so if you take from 2 to 4 minutes, I think we should be fine. So do you want to start?
I will focus in Greece. In Greece, in the case of Greece, we had also the monitoring meeting, and we managed the hubs to see the progress of each hubs, but all the other colleagues could talk about that. What we learned as Greece is that I will talk about some issues, like many of these people believe that they could have also a vaccination after these questions. So we saw that we have to continue this project and try to provide vaccines and more testing about HIV, HPV, in order to have access and progress in their health status. And also, we try to involve everybody in these programs. We had the hubs in Greece, in the area of Africa and in the area of Thessaloniki. Many of our participants were in the area of Thessaloniki, and also with collaborations with other key stakeholders. But we see also that there were also other people that they do not have vaccination, like, for example, we had only the Roma children in the start of this project, and we saw that also the parents, they do not have vaccines. So we find the importance to do the ImmuHubs also in the parents, and we changed this category in Roma people, and we had also the adults. And then another category that we find was the first generation Muslim migrants, that it was very nice to explore their vaccination status. And some lessons were that we need to have a collaboration, all of them, all of us, and a good cooperation. And there were some difficulties in the implementation with the languages barriers, and some of the participants, many times they did not understand the translated tools, so they need us there near them to help them with the translations. Sometimes it was difficult, the booking of the appointments, and also during the summertime, because we had also the team of the seasonal workers, so it was difficult to find them due to their work. And sometimes there were some technical difficulties with applications. And what we would like is to continue this project as I told before, and with our relationships that we are having with these communities to continue and have their vaccinations, more vaccines, to be more vaccinated. I think that's all from me.
Thanks a lot. And what you mentioned, that they wanted to have vaccines, and actually that was something we discussed in the beginning of the project, and it was decided that this is not an intervention project from the vaccines perspective, because that would have brought different consequences for liabilities and other issues. So it was deliberately left out from the project. But of course, I mean, we also in Finland discussed on whether we could then defer them to some other place to get the vaccines. Did you do that?
Yes, because they saw that, as we also Van said, in the first step they believed that they had to do all the vaccines, but then they saw that they did not do it. So they asked what we can do now, where we can go, if they can do also as an adult. So we give them information, and we had linkages with other organizations and the national healthcare system in order to have their vaccinations and to continue this progress.
Excellent. But you didn't follow up then on how many of your
No,
customers actually did get vaccinated?
Not all of them, but we try to have more appointments, because there are people that they keep coming in our social services. The ImmuHubs was in our social service of Praxis, in the polyclinic, in the community center, in the open day centers for homeless people. So we book them appointments, or we're having linkages with other organizations, and we try to follow up with them and see if they went to their appointment, if they did the vaccinations, also with the Roma children, because there are many mothers with their children, so we keep follow them and continue this appointment.
Good.
Thank you.
Any comment from the rest of you? Okay, then Adamos.
Thank you, Hannah. Good morning, everybody. So my name is Adamos Hadjiparais. I'm from Cyprus, and I'm going to give you an overview of the situation in Cyprus. I'm going to talk in details about the ImmuHub project during my talk later. It's important for you to understand that in Cyprus we have now a new health system which was implemented 4 years ago, and unfortunately this new national health system resulted in decreasing the vaccination uptake in the population for many reasons. I can discuss with you later during the break about this. But this is the case, and we need to do something urgently, not only for the vulnerable people, but also for the entire population. And this is a bit sad. I don't know if you're aware about the study that was conducted by the European Academy of Pediatrics 4 years ago on vaccine confidence among 18 European countries, and Cyprus, together with Portugal, and were among the best countries in Europe in terms of vaccine confidence. I know. We were the second, that's fine. But despite the fact that the vaccine confidence is high, the vaccination rate is going down. So to your question, Hannah, whether we are going to conduct similar studies or implement similar measures for the Cypriot population, the answer is clearly yes, because what's going on in Cyprus nowadays is unfortunate, and we need to correct it as soon as possible. I had a long discussion with the Minister of Health the other day, and also with the head of the organization responsible for the immune health system, and they seem that they are willing to change things. Otherwise, Cyprus is going to be one of the countries with not that good vaccination rate. Finally, because I don't want to take too much of the time of the panel, I want to emphasize that we shouldn't forget that the cornerstone of the vaccine uptake are the vaccinators. And I give this name to you because it depends very much on the health system of each country. For example, in Scandinavia, are the nurses. In my country, are pediatricians, or in some other countries, it could be the GP doctor, the family doctors. So we need to concentrate, we need to focus on the people that they are giving the vaccines to the population. And usually these are the people that the parents trust. So if we really engage those people and motivate them to increase the vaccination rates in the population that they work for, I'm confident that they will do it at the end of the day, and we will be in a position to celebrate the date where the vast majority of the children's population will be vaccinated of the majority of the vaccines. And every time I receive this question from a parent, can you please tell me which are the mandatory vaccines? And in some countries in Europe, there are mandatory vaccines, but in the majority of the countries, there are no mandatory vaccines. But what the people believe that, the vaccines that they have been used for many years and they are well known to the parents, they call them mandatory vaccines, which is not in reality. So it's a big discussion that we may have today or on another occasion. So that's all for me, and I'll come back later to the details of the ImmuHub project. Thank you, Hannah.
Thanks a lot, Adamos, and we look forward to your lessons learned from the ivory tower down to the grassroots. But if there is any burning question right now or comment, then please. I just see nodding heads, and we are all concerned about your immunization coverage rates, and actually maybe a comment is that we are the working force is depleting, and then the time that the vaccinators can actually spend time with the parents and those to be vaccinated is decreasing. So that's
and you are tackling the most important issue.
Exactly, yeah.
So you are well aware of the problem. So most of the pediatricians don't have the time to talk to the parents. So this is the problem. And if we realize the problem, and actually, sometimes when I say it up publicly, people, let's put it the other way around, it's not well received by someone who listens to. But you need to redress the physicians, the healthcare professionals are going to devote time for this. But the countries, the governments, and in general the health systems are not willing to do that.
Yeah. And one of the solutions is a digitalization of information and gamification. So let's go into that in the next step. But let's hear from Adam from Poland.
Good afternoon. My name is Adam Sidor. I'm from Poland. In Poland, I'm teacher at the University of Rzeszów. At some time, I worked as director in provincial sanitary and epidemiological station in Rzeszów. So I can say that my role in the project ImmuHubs was dual. My organization received an invitation to ImmuHub from rector medical college, medical and science of University of Rzeszów. My organization is a governmental unit dealing with tasks in area public health. These tasks include supervision over conditions, hygiene conditions, food safety, health prevention, this including vaccination. In our voivodeship for Carpathia, we have 21 units local level and cooperate with units involved in health prevention. So I would like divide work on in the project ImmuHub into two parts. Until February 24, 22, and after this date, after February 24, we live dynamic situation in the place where we live, because our leadership of Carpathia borders deeply with Ukraine. Our leadership of Carpathia accepted 2 million, nearly 2 million people, refugees from Ukraine in a short time, about 2 months. Some refugees from Ukraine who decided to stay in our area. We offered the shelter in accommodation center and private apartments. They were mostly women and children. They needed all help, all had information included health information. Additional education activities were carried out during ImmuHub projects, such as hygiene, healthcare, calendar vaccination, low level. The survey were carried out in 3 places: local sanitary and epidemiological station in different towns: Krosno, Rzeszów, Stalowa in Offranges, food center, and farms employing seasonal workers. It is worth to highlight the high awareness and openness witness of unattended children employed in orphanages, which results in an impressive number of complete VAC app surveys. The online form, the VAC app, is very convenient for children guardians and families to work. On the other hand, we experience difficulties we've collected surveys from Ukrainian refugees, what quite often results in their traumatic experience, fear, and language barriers. Local in Podkarpacie shift the units that cooperate on the ImmuHubs projects include local government units, medical facilities, social welfare centers, students' science clubs, and the International Organization for Migration. In Poland, the representative of International Organization for Migration Poland accepted our invitation, and tomorrow they will share with us its experience on site. To sum up with some numbers, under the ImmuHubs project, employees of the College of Medical Science, the University of Rzeszów, gathered in total 193 reports. 61 health survey reports from refugees and 132 VAC apps survey including unattended children under 12 years, of age 72, was refugees, third seasonal workers from Ukraine, 30. The activities undertaken in ImmuHubs have attracted the interest of international organization, e.g. PCBC, the latest from Stockholm, who visited the refugees place in the Podkarpacie worship in 2022, in Przemyśl station, in Przemyśl. The information about ImmuHub tools were communicated to the Bureau of the High Commissioner for Refugees. My colleague, Paweł Zapolnik, in the second panel will probably inform about the actions that already were undertaken at the University of Rzeszów. Thank you.
Thanks a lot. Amazing work that you've done, and also receiving all those refugees, 2 million plus. Now, my question to you is, do you see that this VAC app and the health app and our SCORE app could be used still in the field in Poland among these groups? Or is it something that is just a one-time experience and then we need to revise?
Please translate, please. I think can we use this application in our surveys and surveys.
Yeah, because it will be extremely important for us to know on how the international migration IOM, how they do they take this on board? Do they want to devise it further, edit it further for their purposes? So this is exactly the kind of thing that we were hoping that ImmuHubs would be doing. Then it could be tailored for the purposes. Barbara.
I just wanted to personally thank everybody on the panel, but the Polish team, I have to say, this is extreme humility that you put here. They have done amazing work, and it's been astonishing me every day. You guys have been at the forefront, and as I said, you're in the very eastern Poland, where across one of the amount of humanitarian sadness, to put it mildly, that you have witnessed while you're doing your work, has really filled me with humility. And I also would like to say that we initially, as I mentioned, had actually planned action over Israel and Ukraine. It was just not possible to fund it through this particular idea of funding mechanism. In hindsight, I'm thinking, wow, what were we thinking in 2020? But we kept these partners on board. One of them was almost single-handedly changed around the vaccination status of Orthodox Jewish communities in Jerusalem. The other one is now moved on to WHO as a young EAP member who's been an excellent vaccine specialist. And in their absence, I also want to thank these two groups that can't sit up there with us right now, but have inside knowledge of the benefit of the project.
Thanks a lot, Barbara. So then we go to Kaja from Serbia.
Yes, thank you. Hi everyone, I'm Kaja Damjanovic from Serbia. And Serbian team within ImmuHubs project, we are all social scientists, mainly psychologists. So within working during this project, we were involved in many things, but what was particularly interesting for us is a question of communication and trust with our target populations, and we have three as every other country. And they were, we are university affiliated, so we had to, and we partnered with local communities, usually via civic organizations or societies, to get in touch with our populations when we wanted to talk. And for us, those were war veterans. Usually they are as well papers people, Wallachians from east of Serbia, which is ethnic minority living in mixed ethnic area of Serbia, and Bosniaks or Slavic Muslims from south of Serbia. So they were not close to us physically, and we partnered with other organizations to help us get in touch with them. And so those three groups differ in many aspects, but when we are talking about vaccination stance, and what did mostly backup did for them was, and that was the first thing that I mentioned, was opening the communication and trust and interest toward that issue. And what we have learned is that people, I mean, coming from the field of social science, it wasn't a big surprise for us, but it is another layer of proof or evidence that people are indeed interested for that kind of topic and curious to know more about vaccinations, and they do not know anything whatsoever, which pre-post and post-test showed us quite clearly, but they were open to participate and to know more. And so that was the similar issue which you had for one of our groups, because our groups, they're not diverged from healthcare systems. So they're not refusing to participate in official healthcare system within states Serbian healthcare system. That's fine, but people usually do not know, and that's what our experience shows us. They do not know how much they do not know about vaccines. So the amount of information, I mean, seeing the knowledge gap they had made them interested because it's their health, made them interested to know more. So for some groups, two of our groups, it was quite easy because they had place to go, which is within the healthcare system. In Serbia, that's usually for when you have children, usually pediatrician, but for general practitioner for other population, but for paperless people and war veterans, it's quite challenging. So because they're usually paperless, so they're undocumented for various reasons, and then organizations who are in field, varying workers can help them. And also there were some experiences because we had partners, they were quite, I mean, I don't want to sound pathetic, but some sad stories where you had a person who was fully embedded in society and had access to vaccination and knows so much, and now he is homeless and cannot access vaccination due to those documentation reasons. So you could see everything in field. What they particularly emphasized, and I will just not spend too much time, what they emphasized is that maybe when they're getting informed about vaccines mentioned within backup, maybe there should be some base of knowledge coming from maybe ImmuHubs project or other partner organizations we heard today, many, where informations about vaccinations are online. We all know that they are available, but they're usually not ordered, or they're not following the questions that patients or lay people have, which we presumably will hear from Arya. So lay people do not think as medical professionals. So they said maybe some link that will answer particularly their questions, not science-wise or medical-wise, would be useful asset and addition to these kinds of apps. And they had pretty much positive experience using this, even though it was one time, but we see it as a link to get back then to the healthcare system or some professional or I don't know, any other person, because it's broader societal questions. So any other person, teacher or within school or local community who will know about preventive behavior, medical preventive behavior. So that's
Thanks a lot. And just to clarify, the paperless people that you're talking about, is it so that they're not entitled to any health services?
They are. So, I mean, state provides them, but it's very complicated for them due to many other reasons, such as comorbidity with other issues, or they're not functional enough, or they do not know how to manage all the bureaucracy. So they are, of course, provided, but they need help from us to go through that system and to, yes, they need help from the same experiences. Yes. So they are allowed, and it is provided for them, but it's not easily accessible like for the other population.
So
it's not only access, it's also trust and hesitancy, and in their case, managing the complexity for them.
Right. Yeah. So in that setting, the backup is just one tool, but you need to build a whole lot more around it.
Yes. So it has the limitations, but that's fine.
Sure. Yeah. Any burning question to Kaya? Yeah, thanks a lot, and let's move on then to the champion Portugal.
Hi everybody, good afternoon. I hope you're all Well, welcome. So, the division in Portugal is really high, and when Barbara proposed to make this research project, I thought there was no room, but of course there is room. And in Portugal we did 4 groups, and actually some of the groups really needed to be approached. The backup was very quite interesting tool that brought us to them. I will be making a presentation tomorrow, exactly talking all the issues on each group. But I agree with Kaya that several things are very important. One of them is being open-minded. I confess that I was really having trouble on anti-vax. And exactly one of the groups that was more challenging for me was the Waldorf School, which is related to alternative way of thinking and anti-vax, and that was really difficult for me. Anyway, all the whole group, including some collaborators, were really very thoughtful and never give up. Because the number of schools we tried to contact were many. But finally we get in touch, and what I learned is that the most challenging group was the group that I learned more with, and I think everybody learned, because we cannot, we have to be open-minded, and we have to create trust. Trust is fundamental to rise to those small niches of difficult to reach people. So in this, but I will tell you more about tomorrow, and I hope you will hear tomorrow. And the 2 things were very clear: being open-minded, no preconcept against. We can always talk, and we can always exchange ideas, and some of them will be useful for them, but also will be useful for us. And another thing is what we learned in Helsinki about design thinking also helped me a lot, because not with this group, but with another group, which was Ukrainian migrants, not war migrants, residents, and at a certain point, we have to change our strategy completely, because what we thought it was possible, it was not possible, because of issues that happened in time. So, at this point, I have to change completely, and the strategy, the certain ways of doing it, we just had to move on to other strategy. And that was really an interesting thing at a certain point, and you will see it tomorrow. So don't miss my lecture tomorrow. Okay? So trust and open mind is 2 important things to achieve the success we have.
You're making us excited. I mean, everybody needs to come back tomorrow to hear from you. Thanks, Anna. Any question to Anna at this point? No, we'll wait for tomorrow. Yeah, and then we go to Kalpana from Finland.
Hello everyone, I'm Kalpana Masala from Finland. So I'll start with a short summary of our 3 hubs and what the group and how we did it. The first one, I guess that's the most biggest one, was we collaborated with NGO, is the area by Mr. Piskus, it's an activity center for elderly immigrants in Helsinki. So like there were foreign elderly immigrants, age 50 plus, with activity 85, and then it's kind of, NGO is kind of informal gathering setting where they can just do discuss what they want to do, go on hikes, bake, or learn music or write poems, whatever, that kind of informal gathering. So it was really a nice place for us to start. So and they received us quite well. In the beginning, we also had like this is the most of the space like if we could also give them vaccination there, it would be easier for them. And then during the COVID time, it was like kind of convenient for them to, but also we decided like, well, this is not an intervention project, but the staff at ADA, they also help military immigrants, for example, for those who have having language difficulty to book appointment for vaccination and other health services to the nearest health center. So like it really work was in our favor, and they were interested to learn and hear about this. So, but only one challenge is we face here is about the challenge of translation. And there was the group of, for example, quite many Chinese group. I think that was one of the largest, and in our backup, that language was unfortunately not available. But also there was other Vietnamese. But we managed to do it. We need like, I guess we need translators, and then when you did that, there are also some administrative issues. For example, in the grant agreement, we cannot hire translator and pay on the cost. So Hannah sorted out like all the administrative issues, and she also did answer the difficult questions. And yeah, so it was really nice. And most of my colleagues here, she did excellent job of field work. She collected all the data, and then yes, it was really commendable work she did. And the other one was undocumented migrants in Helsinki. In the beginning, when we started, like in Finland, this particular group had no access to the regular health services as the local residents. But in 2023, a law was passed, so now they can have like health services access. So at that time, this NGO, Global Clinic, it was providing them health services. So we collaborated with that NGO, and that was our hub, so we could go and collect data there. But the scenario changed after the law was passed, and they could have access to health services more easily. So later it was a bit expanding to other groups as well, refugees and asylum seekers. Yeah, in the beginning it was quite challenging to find the participant itself. So yeah, we have to use kind of multiple contexts. And again, say Mercy, she did a really good job using her own network and network from yeah, from referral from parents and this and that. And that's how we did it. And the third one was second generation Somali immigrant. And then this one, we have colleagues, Idil Hussein. She helped a lot with organizing interview with this group. And yeah, and then there were, of course, there were some challenges. And then we have a very exciting presentation tomorrow from my colleague about the lesson learned. I think it will also cover the challenges in the field from that. But we have few issues with like scheduling, and then from the app also. The backend is really good, but also I think there is also there's some like further I don't know, language issues to be fixed. I know the amount of funding we have budgeted so much, but still I guess if you want to translate this, and we're talking about sustainability, then of course it has to be taken into account. But then also that sometimes the app were kind of freezing at the moment, and we have to restart again, and we anyway the participant. These are small stuff, but still we have faced those challenges. I don't know if other groups you face that, but also like yeah, and yeah, what else? Well, yeah, those are the main issues, and then sometimes like the quality of translation I discuss again, the participant, even if when we have the translation, but they are kind of they are still not understanding, I don't understand what is this kind of so if we need to hire another translator, that it would be so yeah, there was I think it is more basic around the backup. But overall, I guess it went well. But yeah, these are the most like the general challenges or experience that we faced. I was most of this the field work the colleagues did it because there were some delays as we know the development of the backup, and I was away on a maternity leave, and then I was right back after all the data collection was done. So well yeah, but yeah, I know that I was involved with planning and other things, and we did this organize it or other things. We are also the evaluation, we did the internal evaluation. So, but yeah, overall, like it was really like, a learning experience for me personally. I have never been involved in this kind of multi-country project. I learned a lot. And also, like, yeah, I learned a lot to work under sometimes under pressure, sometimes under different difficult situations. That's all. Yeah. I think please.
Yeah. Maybe I'll ask you first because I mean you were Finland was one of the few places that elderly migrants were approached. I mean, if you look into Vanna's presentation, the mean age was like 31. So do you think that the VAC app is also suitable for elderly people?
It is suitable, but I think they needed some help. If I remember correctly, I feel they needed some help, and I think they prefer mostly interview method rather than doing it themselves. So yeah, I was not there while doing the data collection. Maybe where she would like can explain it later.
It's very common that the Chinese were extremely tech savvy. So really like serious, they were doing it better than I was able to do, I think. But depending on which part of the worldwide economy.
Yeah, Barbara.
Yeah, it's interesting to hear because there's some things we were anticipating at the beginning, you know, thinking, okay, let's keep remote areas, people don't need to download anything for privacy reasons. But then, of course, you depend on the internet, right? So if you don't have Wi-Fi, you can't do it. So there are these, trade-offs that we have to think about. And of course, we thought about 20 languages. And then there are a few more that we would have liked to have. So there's a lot of wisdom going on that side, but I fully agree. And that I thank you now in person for your patience, because we did have a very expensive translation agency that supposedly had the best linguists provide 20 language translations, and it needed all of your input, user testing, feedback, and the technical team's patience with fixing these bugs or these questions, from Anna telling me this is not Portuguese, that's Brazilian Portuguese, and I said this thing in Serbian makes no sense to me. It means, are you getting the disease, or are you protected from, like, little things that normally a linguist should know. So my lesson personally is you can't really know ahead of time before the translation agency. And while computer-generated translations are getting better and better, I think the future approach would be using an AI-based translation mechanism and then getting funding for the user testing so that time can be spent wisely, that people are actually going to use it in the field. That would be my personal take-home message. But yeah, I often thought that even the German version and the few languages that I speak, even the great one, sounded sometimes like they were already machine generated, but not well machine generated, not like they were done by an actual person. There's no way we can control that. So I think in the future there would be the idea of using machine translation right away, and then getting user testing done, and that would be my plan. But thank you all in person now for your patience, because that was taking some time. And at the same time, though, I thought it was good that we were able to roll out the ImmuHubs when we did, which was just about the time after the pandemic when we could safely open physical spaces and invite people there. So that thank God coincided. Lucky on that one. Thank you.
Thanks a lot to the panel, and now we have a 10 minutes coffee break. We're a little bit late in our schedules, but I hope it's all right. Yeah. I don't know. I mean, Jesus is the other. So please come and take your seats, and we'll hear from Adamos on stepping outside of the ivory tower, the ImmuHubs AMIT communities. Adamos, please. I think it was Barbara that gave the title, but I mean, Adamos is very free to revise the title if you want to.
I will explain to you.
Yes.
So hi again. I was asked by Barbara to give this presentation today with this title, Stepping Outside of the Ivory Tower. I think Barbara meant that, you know, we had to leave the luxury of our offices and go to the hubs that we have to go. But Barbara, let me tell you that it was fun for us. And we were looking forward to those days to leave the office and go to the hubs, grasp a coffee and talk to the people. So it was great fun, and we enjoyed it very, very much. So just to make the long story short, I can tell you that this project for us was a piece of cake. And I mean it. And as you could see from the deliverables, Cyprus was the country that was delivering everything in time. And this happened for two main reasons. Number one, Cyprus, as you know, is a very small island, less than 1 million of population. So we know each other. And number two, myself and my colleague Elisabeth, who worked very closely with me for this project, we have been involved in similar projects in the past, so we were very experienced in recruiting people. And the key element of success for this project is to recruit the participants. So let me go through the presentation. I'm going to discuss with you how did you manage to approach the 3 hubs, the homeless people in Limassol, the Greek Orthodox community in Nicosia, and the Turkish Cypriot community all over Cyprus. And at the end, I will give you the conclusions from our end. The first hub was the homeless people in Limassol. I can confess that this group of people was the most difficult to approach from our side, because, you know, these people live in the streets, and we tried to find a way how to reach them. At the beginning, we thought that it could be a good idea, you know, to start walking around and start talking to them. We tried once, but then we realized that these people are very reluctant to talk to foreigners. And then we thought that that's not a good strategy. Let's find another strategy. And I will share with you what we did. So the main characteristics of this population were the fact that it was really difficult to reach them. Vaccines is not their priority, as you can understand. They need food. That's what they need. They don't care about vaccines. And none of them, literally none of them, had the health booklets. So we changed strategy, and we approached the municipality of Limassol, where they have a center for support for these people. And at the same time, we found a non-for-profit organization called Sedia. So these two organizations, they provide food to these people, and actually they know them. They know their names, they know more or less where they stay or where they live. So we had a very detailed discussion with these people, and we agreed that we could meet these people in group every time they come to get food. Every time there was an office where these people go every day to get food and sometimes clothes, we were there waiting for them to come, and we were open to them to start discussing at the beginning on various issues, and then we disclose our profession and the reason why we were there, and finally we managed to recruit those people to the project. So you need to use your imagination, and you need to understand who is the key person or who is the key organization to approach a specific hub. tools that you have to have in your hands in order to approach these people were the friendly manner, the kindness. You need to make them feel that you respect them, despite the fact that they are homeless. You need to be very patient, otherwise they will leave. You need to talk on football, on whatever, and then you need to grasp, the opportunity to start talking about vaccines, about their health at the beginning, if they have a health issue that they might want to discuss with you, and then you start discussing about vaccines, and the answer is always the same. Vaccines, well, I don't remember when I received the last shot. Why should I get a vaccine? And of these kinds of answers. And of course, as this mentioned from the previous colleagues, the honesty and trust are mandatory cornerstones, elements to any relationship. So that was the most difficult hub for us. The other quite difficult to approach is the Greek Orthodox. When Barbara approached me and told me that, in Cyprus we have these 3 hubs, I told her, come on, Barbara, how can we approach these people? I mean, who are they? I don't know them. And well, there was an article in the newspaper talking about these people. Yes, there was an article, but where do these people live? Anyway, so again, we had to think about ways to approach these people. These people, they usually live in an area close by the city of Nicosia, which is the capital of Cyprus. I talked to some colleagues of mine practicing in the area to give me some more information about the background of those people. And then one day we decided that we had to attend the service at the church. And then we can find people, that they are very religious, because these are the people that are against the vaccines. And, although I'm not a religious guy, I go to church once in a while, maybe once a year. I went to the church. And then we had to drink coffee with the people, find, who is in charge of that community, and build the trust between that person and us, and then trying to find the people that are very pro to this guy who is called Morpho Bishop. After that, it was quite easy to recruit the participants, and it was only a good surprise that most of the children of this family had a very good vaccine uptake, despite the fact that we are influenced by this bishop. And despite the fact that, their parents sometimes were very reluctant to vaccinate their children. So that was how we approached that community. And apart from the characteristics that I have already shared with you earlier for the first community, the fact that myself, I was, a familiar face for them was quite important. I used to have a TV program twice a week, so most of the people in Cyprus know my face, and that was a huge advantage to convince the people to trust you and to talk to them. And most of these people are very well educated, so they are looking for evidence-based information, and you need to be very well prepared to give answer to their questions. Number 3, and the last one, and I hope that haven't taken much of your time and try to be sharp with the timings. Is the Turkish Cypriots working in the south? Most of the people live in the area called Pila, which is very close to Larnaca General Hospital, where I live and where I work. So I have been a pediatrician in the area for the last 32 years now. So almost everybody knows me, and that was very easy. That was a piece of cake. So we didn't have any issues, any problems to approach the people. On the contrary, they were very happy to talk to us. They are very open, and they found themselves that how can I say, it was for them an advantage that we had the opportunity to talk to us and explain to them about the vaccination status of their children and to talk about vaccines. And I can also tell you that the majority of them came back to my hospital and gave to their children the vaccines that were due at the time that we had the interview with them. So that was a very nice experience, very easy for us. And as I explained to you, the fact that we have been working to that area for so many years was an advantage for the group on the fields. So in conclusion, for us it was an amazing experience to leave the office and go outside and talk to the people. A new experience. It was more relaxing for us. We managed to deliver everything in time, not on time, in time, before the deadlines. And the number 3 conclusion is that explaining the program in detail and make them understand is a vital component and a vital element of success. Thank you very much.
Thanks a lot, and you certainly are a TV figure and a well-known person, so it's no wonder that it was a piece of cake. And that's actually the key, the trust and the fact that you're familiar and people feel familiar with you. Questions to Adamos at this point? Yes, please. Anna, maybe. But there are people online, so.
Homeless, piece of cake should be chocolate cake.
Thank you, Anna, for your comment. Yes, Aplana.
Thank you, Alex, for interesting presentation. I just want to ask, well, it was relatively easy for you, but what are the challenges, if you can name a few? Did you not face any challenges, or they all piece of cake?
The only challenge we faced was how to approach the homeless people. The other 2 hubs were not a problem for us at all. But once we found our way to this, to the NGO, the CEDIA, the non-for-profit organization, and once we talked to the municipality of the area, it was easy to approach the people. Well, we as you all know, we have the technicalities issues. So sometimes at the beginning we have, communication issues, but I don't think that this is the time to discuss about this. But this is a time of celebration.
That was a diplomatic answer. But actually, you're not in the next panel where we go discuss on how to adopt the ImmuHubs approach elsewhere. But my question to you is on are you planning on continuing this kind of work in Cyprus?
As I explained earlier, Hannah, Cyprus needs something has to be done in order to maintain the vaccine uptake. And, these vulnerable populations is a small percentage of the entire population of Cyprus. And I think the priority now for us, for me, and for the government should be to increase the vaccination uptake to the entire population, especially to children. We had an outbreak of measles recently. 9 kids who were reported having measles. We have a large number of refugees coming from Syria and from all over the neighborhood countries. In my departments, I have been working there, as I explained, as I said earlier, for the last 32 years. And in the past, we didn't have one patient with tuberculosis. And nowadays, we have one every 2 to 3 months, severe cases with tuberculosis. And if we don't start working to increase the vaccinations, then we are going to have a problem with the vaccine preventable diseases. And this is really very sad for a country like Cyprus.
I guess for all the European countries, I'll be addressing that tomorrow. Unfortunately, you're not here, but thanks for sharing the Cyprus story, because you're not alone. There's plenty of measles in Europe actually right now. Okay, we're running behind schedule, but let's take the 3 questions that you have.
I just wanted to ask with regards to timing, because everything was delivered on point, fair enough, but how long does it take, 40 home labs, for example, because you have to go the routes to actually get back to them. How long does it actually take to do that work? Would it take you to do that work, or will you know very, very long? And also I was curious about how many of you were on the ground? Because it's you, but not only you, I guess. So what is the resource that is behind that work?
It's only 2 people, myself and a colleague of mine. So you need some time to find the ways to approach these people. It could be days or weeks sometimes. And then you need about half an hour per participant, at least half an hour. So in a day, you may recruit about 6 to 8 participants. Nice to see you in person. We've exchanged a couple of emails, but yeah.
Then there was,
Just a private question. There's expectations from the church and who attending services right now?
So
you don't have to answer.
You look like my mother. My mother is a religious person. Every time I'm not going to the church, he's crying, and she's still crying.
Okay, the very last question.
Thank you. So I'm interested on, you mentioned a few aspects that make the project successful to enriching the populations that are actually against vaccinations. And I'm wondering if there are any more merit-based discussions, or like what arguments could you use to actually counter some of the beliefs or some of the cultural prejudice against vaccination?
That's a very tough question, and I would need at least an hour to address your question. In Cyprus, I hold a conference for parents for the last 15 years. And we address this issue almost every other year. The problem with the anti-vaccinists at the moment in Cyprus is not that big. And mainly comes from well-educated people and from people that they have immigrated to Cyprus. German people, Ukraine. As you may know, in Ukraine, the vaccination rate is very low for many reasons. Number one is because they don't trust their government, or they didn't trust their government. I have visited the country and I talked to the Ministry of Health twice as a president of the European Academy of Pediatrics to find out what are the problems of the vaccination, of the low vaccination uptake. So it's a multifactorial issue, and it's you cannot tell that you know, these people are religious, or the people are insane, or these people you know, most of them, they are anti-vaccines because they don't want to give the vaccines, and they don't give you a tangible answer of their position. And these are the most difficult parents to convince to have their children vaccinated. But fortunately, the percentage is very low. It's less than 2%.
Thanks a lot. And pretty similar situation in Finland. Less than 2% are those that are completely against vaccines. And we let them be, because the effort that it takes, like you say, hours of discussion, and still you're unsure on what happens. And meanwhile, you're having measles outbreaks, so you have to concentrate your efforts on where you see the return value more.
The only way to convince people is if one of their children gets one of the diseases, and then they run to vaccinate the entire family. But it's a pity. I had one child with measles admitted at my department. That was a family that were anti-vaccines, and you know, the next week the whole community was there to get their children vaccinated. But this is not, you know, the way forward.
Exactly. And that's actually the reason why in Finland we had to change. We had the naturalist Swedish-speaking people as one of our target groups, but because there was a measles outbreak, they all wanted the measles vaccine. So the kind of ground disappeared for us to do the work. Nature took care of it. Thanks so very much, Adamus, and we look forward to your next show. To move on. From THF Finland, and Gary Finnegan from Vaccines Today. Should I sit here?
So, first of all, thank you all for being here. And I wanted to say thank you, Adamus, for your very lively presentation. I have to say he was the winner also of the Design Thinking Afternoon in Helsinki, when he proposed we should have a Britney Spears concert and then give people vaccines. I remember that one. Okay, so first of all, thank you all for being here. And I wonder if I should, I feel like I'm standing too high up. Is this better? So you can see. Trying to not block anybody. So the question is really what we have been starting to ask during the previous presentation, slowly. These 3 years just flew by, and the question is, where do we go from here? And there will be more about this tomorrow, but we would like to pick all of your brains. So we have time. This is the last session of today. If we go a little bit beyond, that's all right. But it's very important that we receive your feedback, because that, I think, is the biggest challenge with European projects. Is number one, engaging stakeholders and really getting their feedback into the project. And secondly, digesting, as Hannah called it, digesting what has been done, having enough time to analyze, to learn, to distill the essence of what we've done, and to see what the steps will be done. So I would Start on the left side.
We're going to start with new people.
Start with new people. Okay, Gary is almost here. Okay.
Not so, well.
I've got a question.
Yes, of course.
Or maybe which has to do with, since I've been here listening forever, but is to which extent the Commission has provided feedback to you. How this amazing outcome, I must say, I'm super impressed. I'm really super impressed because seeing such an initiative like this, so well done. Great initiative on the ground with effective outcomes. This is not seen everywhere. So what is the feedback the Commission provided to you?
We're not there yet. So we had the interim meeting in Helsinki. So, one of the challenges was, of course, we started in the middle of the pandemic. So the first meeting we had in person with each other, a little bit autistically, because we met, first of all, as a group and try to figure out where we are, how can we move forward. But we did the design thinking exercise to think about what happens after the project is finished. There we had an open, I think it was recorded, an open discussion about how do we manage this and how do we get this finished on time. Now we're finished and we are going into the next phase, which is really distilling the results, doing the technical reporting. We have 6 deliverables due this month. Most of them are about to be finished. They're the end of project booklet, which is more managerial. Then we have an impact statement. We have the white paper from IA. We have feedback from EAP on how communication went. So all these lessons are being distilled right now, are due the end of this month. So we just about finished things on time. We didn't want to go, what is, I think, seen more with European projects more and more often, is that they go into an unpaid extension. I didn't want to do that to any of the teams because a lot of people have hired also young staff and I think they need to be paid. So there's still a 2-month reporting period due at the end, that opens when the project finishes, and it's the technical and financial reporting. I have to say that Paula has been very supportive of the project. She's a phenomenal project officer, but she was also very busy. Number one, Chafea, where we applied, became Hadea. They moved from Luxembourg to Brussels. And she also, as she mentioned, has the HERA file on her desk, which is a major issue. I think what I'm hearing between the lines is that people with the Commission that I met at some of the normal EU meetings are concerned about the momentum following the roadmap on vaccination. That was a major effort, and it came after major council decisions. And then the pandemic kind of proved that this was necessary. And now what? We're ending this project in the know what phase. It was the last annual work program of this 3rd European Health Program, which sounds very bureaucratic, but that's how things think there. And the question is now, are we able to distill this and create a momentum? I can't say that yet, it's too early. The interim funding was approved without any changes. That's a good thing. It took a very long time to get there. Formatting things with deliverable reports and all, as you learn as you go, but all of these deliverables so far are approved. Everything was on time so far. The interim funding was approved fully. Now is the question, what comes next? I will talk about a little bit about that tomorrow. I have a few ideas, I think. What fell on our lap is that people in our network asked us to do an Erasmus Plus project together. We did file that one. And to my great surprise, I was approached by a team from Ethiopia if we could do EDCTP3 proposal together, which we did. We ended up in phase 2. That was due early this month, last minute galore, but we submitted a stage 2 proposal with DRC, Tanzania, and Ethiopia, and also Hannah's team in Finland, to continue the evaluation continuity to see if we can be even more crazy and scale this approach to sub-Saharan Africa. No idea if we will be successful or if we get the stage 2 approved, but that's one of the things going forward. All the partners here, I think, will be more than worthy of more proposals going forward and more collaboration, and with each one of them, I would love to continue working. This happened very quickly during the pandemic, but I think this team has proven to be efficient and extremely productive. And I know I was the one whipping everybody to the finish lines and sending the unpleasant reminders and the emails with, let's start with urgent or action required. And I know that's the bad cop position, but what was delivered in the end is quite substantial, and there is more to be done to distill, compare, learn, and pick up. And tomorrow is entirely dedicated to how we can adopt this into the future, whereas then Friday is more into the nitty-gritty, how do we get to the final report? I hope that helps to answer, but there's more to be done. And I think we need to be more present in Brussels as a consortium also. So, yeah.
Maybe just jumping on it, just to initiate engagement.
Yeah.
I think visibility is absolutely critical. Visibility, but large visibility, and there is a strong network here, but beyond that, so more than happy to help supporting that. And then is what are the tools, because what we have, going back to the roadmap, the European vaccination roadmap, there is something, the European information portal, which is there, whoever is using it, but maybe they need us to use it and to make it actually useful.
Yeah.
I think it's a platform that deserves to be used and potentially find a way to leverage work here. There are country-specific initiatives with deliverables, with tools that needs to be made available. And maybe we can definitely use that EU information portal as a platform.
Yeah.
That's what I would think first, which would obviously engage the regulatory agency or PCDC, because they are the one who are hosting that platform. So I will start with that.
Yeah, it's a very good idea. And one thing, thanks to Hannah, I think when we initiated the VAC, as I told you, there was also a plan for a European vaccination record, which I don't think yet has materialized. But the VACA is a very good foundation for something like that. And Hannah's input early on, which I found very helpful, was to say, we said, let's direct the questions according to the vaccination record in the particular countries. And her idea was to use the ECDC vaccine scheduler as a foundation for that, which is what we did. So as we have more funding, we can automate that process and make sure, they're not just refugees or people evacuating from a disaster, they're also just normal European citizens who move from, I don't know, I talked to one of the key people in another consortium that we're a work package leader in, and she said, I'm moving from Brussels to Spain, and both pediatricians hate me. One of them says, I don't want the vaccine yet because it's not needed yet in Spain. The other one in Spain says, how could you not have received vaccine X, which wasn't required in Belgium. So this question that Adamus mentioned, what are the obligational vaccines, or this kind of idea, or what is common sense, is not common sense in all European member states. And that creates, in my personal view, among vaccine recipients, the idea that the experts don't agree. So I do think that the tool that engages you and makes you think, okay, what is my child protected from? What am I protected from? Starting with that thought and already having that baked into the system of the questions that you're being asked can help, rechannel some of that energy into what am I safe from? And my very first sentences when I talked about these policy briefing notes in 19 that I wrote, my first learning there was this l'Europe qui protège, the idea that the EU is expected by its citizens, no matter where they come from. And I think that the Eurobarometer is even more powerful than the Vaccine Confidence Project. I think it's more important to embed, my personal view, the vaccine topic into general topics of health and well-being. Because then it's no longer alien, then it's something that is part of being safe from accidents, from terrorism, from all these other things that people worry about. Health is the number one. So when you say which budget is first being cut, how on earth can you cut the budget that is most important to the citizens? So if protection of my physical well-being is my number one concern and expectation from the Commission, how do we get there? The challenges, in my also personal view, is that the many citizens in Europe overestimate the mandate the EU has on health. And a little bit that is fostered by the country. I can say that for my own country. If things go well, it's been Germany that's in charge of the health of the Germans. But if something goes wrong, it was the EU. So I think we need to learn from each other and think of it in the same energy, and then we can sort of build this health agenda forward. I think, and that's what our design thinking exercises have taught us, the less you treat vaccines as an external thing, the more you keep it in line with bicycle helmets. You know, you have a toddler in the house, let's protect the electric outlets, let's make sure you have a seatbelt on. Then vaccines become an organic part of keeping yourself protected, and that should go back to the Commission, I think, as a job to do. That's a very highly philosophical answer, but I think it needs to be part of that.
Maybe can I just say something reflecting on what you just said? I think, well, the first thing is health is not an EU competence. So health lies in the member states. That being said, that doesn't mean that the EU has been taking and is taking more and more an active role on this. So it's important to see this, as you say, zooming out a little bit from the vaccines, putting that in the general context of health, well-being of EU citizens. There is the European Pillar of Social Rights that has a pillar on health, access to health, universal access to health. And to the topic of this panel, so first of all, I'm Johanna Schima from My Mother's Matter. We are members of the Stakeholders Forum of ImmuHub. We work and defend the rights of mothers. We have delegations at the UN, the EU here, and UNESCO, defending and bringing forward the rights and the needs of mothers. So we play, and I think it's important for us as stakeholders, or as first contacts of many pediatricians, and as you pointed out, I think in the project there was a part on the drivers of take-up of vaccines. It was identified that the families, mainly the decision of mothers, was a main driver of take-up of vaccines. So we are an important stakeholder. And I see there many important links to how can we evolve and develop and make it sustainable, this project, because it's very important. To link it with a general view of health. I have written down some things that I think the project has to show and to maybe grab on this. I think that besides being a vaccine-oriented project, I think the project goes beyond that. I think it strives to, as we saw it in many of the inputs today, and we're going to see it tomorrow, on bridging the gap, especially reaching out to vulnerable communities, to increasing health literacy, which is very important. We need to empower families, we need to empower citizens, we need to empower, for us mothers, to be able to make the right decisions, but if they don't know and they are not informed, they cannot make the right decisions. We need to give them the opportunity to decide by themselves, or decide with their known background, with knowledgeable and I also think that the project has worked and shown very, very powerfully that difficult to reach geographical locations, difficult to reach populations. All these are important things that the project has already managed to do that can be easily replicated, because homelessness or churches, or they exist everywhere. And I think that's an important part of the project. I think that has to be taken into consideration. And one thing that I think is also universal, well, it's not shown by the project, but is put in evidence, is that families' fear, families' worries when one family member is sick is a universal feeling. So universal feelings of not being able to solve what their child is going through, that it works, not knowing what to do. This is something that the project can capitalize on, knowing that all parents want to do the best for the children and they want to make it, to give them the health that they need. And for us, when you empower and you bring the literacy to mothers especially, they pass it on the children, they pass it on their families, and they impact communities, huge communities. Then this becomes not only communities, but cities, countries, etc. So I think these are points that the project can work on and can show in order to focus and zoom out and say, okay, vaccine is just one point of health. It's a contributor to health, but it's not it. There are many more things that the projects like this can do around Europe and abroad, as you're planning to do. And there I think that you cannot say, no, this is not our competence, we don't care about our European citizens' well-being, because it's not true. They have a mandate on that, even though it's at the national level to implement. But I think on the general approach, the EU can produce and has done it, recommendations, suggestions, papers, strategies that they publish, and so I think these are, I mean, I don't know if I left some things that I have written down here of what I think the project can work and say, well, one thing that I wanted to say as well is the project also went bottom up, and I think that's very important. I think when you go to the homelessness and you talk to them and you convince them, you are not just indoctrinating them, and I think it's very important. They feel that they can make their own decisions, and this is very important because this is sustainable. You cannot just impose on the people because you are the authority or you are the knowledgeable person. I think it's important, and this project shows it, is you went bottom up. And that's something that is fundamental. This means that the people integrated all their beliefs and they can reproduce it in many other aspects in their lives and search for well-being and aspects or issues that can affect them positively in their lives. So I think those are my first reflections on that.
You wanted to say something?
Just a comment, because I listened earlier about the WHO and the CDC, and I believe that our aim is to protect the population from the vaccine-preventable diseases. And we shouldn't underestimate or neglect the politicians. And I was put in the same basket, politicians and some of these organizations, because they are influenced by the politicians. And one huge step forward is the e-vaccination passport. This is my dream, and I have been discussing this with the ECDC for the last 10, 15 years. And, you know, most of the people there, they claim that it's difficult to implement for this and other reasons. And finally, we had the COVID pandemic, and overnight, we had the application of the COVID vaccine. So this shows very clearly that this is doable, and it's up to us to make it happen. So for these people that we are all sitting here and we all have the same aim, if we really want to increase the vaccination rates across Europe, we should work to have a very simple application, which is called the e-passport for kids, common for all European children. It doesn't mean that we have to follow all the same vaccination schedule, but this will help all of us to increase the vaccination rates.
And he's speaking for my soul here, Adamus. We have written indeed a tender for a European vaccination pass, and Adamus was part of that together with one of the best digital health organizations in Europe in Potsdam, at the National Institute, and Kantar Public.
And it's so funny to talk about it now in hindsight because this was submitted months before the pandemic. And the website to which we were supposed to submit crashed around midnight. And our thing went in, I think, 28 seconds too late or something like that. As a result of it, it was never looked at. We had written, I think, submitted 40 documents in time once again. But so I think that's not, that's maybe, I don't know, some voodoo or some karma, but I think we can build on that now because we have established what we need to do. And in my view, talking about the bottom-up approach, vaccination schedule, the simple idea would be to have an instrument that, again, only the compliant people will use, and will send you a reminder, and this and that. The bottom-up approach here is important. So getting people interested in what they know and don't know about vaccination first, and having it be a vaccination record as a positive side effect, that, I think, is where the backup is interesting. Because it engages people who don't want to use a vaccination record in the first place because they don't think they need to be vaccinated. So getting these people into the conversation, now you have a traffic light system sort of printout at the end. You can take that to your healthcare provider and say, well, I wasn't certain, is my kid protected from, I don't know, tetanus right now? And you tell me I couldn't read the scribbles that you put there. That's going to get people to not just have a record, but feel it and make it work for them. I think that's the closing the loop is what the Vivi think tank always talks about, closing the communication. So I've had the vaccine, I should be protected. Now my kid has something that looks like it. What is it? Is it a vaccination failure? Is it a different virus? Asking the doctor from the patient side is what works better than the doctor asking something from the patient. And that's, I think, what Johan was trying to say. You are next.
Okay, so let me introduce myself first. So I'm Mohammed Al Hakim. I'm a medical epidemiologist. I'm currently working as a technical officer for international health regulations in the WHO Eastern Mediterranean Regional Office. So I have been working with WHO for the past 10 years. I worked in different contexts, like I have been in East Africa, in Djibouti country office for WHO for 3 years, and with the regional office for 7 years. So let me first talk a little bit about the different contexts from Europe, the context in Middle East, North Africa, East Africa, and West Asia. So we have completely different perspective for vaccination. But let me first ask a question. Do you know today, 24th of April, is it like special day for vaccination? Does anyone know what is representing today?
It's vaccination week.
European Immunization Week.
And international.
So Global Immunization Week starts on 24th of April. And does anyone know why? So today is 50 years since the API program started by WHO in 1974. So it's the 50 years exactly since it started. So it's a very special day, and I was really happy that the conference or the meeting started on this special day. So the context in EMRO, or in the Eastern Mediterranean region, it's different from one country to another. Actually, the region is composed of 22 countries. It extends from east in Pakistan to west in Morocco, from the south in Somalia to the north in Syria. So, for example, I will start with my country. In Egypt, for example, vaccination is mandatory by law. So we don't have the choice to say, yes, I will get vaccinated or not. It's by law. We have, for example, when I was born, the first 24 hours, I took the first shot of BCG. I took the first Sabine vaccine for polio. My parents were not even asked if I have to or not. And the good thing that the advocacy for the vaccination has been done by the government for maybe 50 years. So there are zero resistance from any parents for their children to be vaccinated. So even the children in Egypt who are born in small villages, not in hospitals, what happened that they send like mobile teams, door-to-door vaccination. They are doing it on a regular basis, and the government now in Egypt, the Minister of Health, they have huge experience in doing this. Another context in East Africa, we have countries like Somalia and Djibouti, where vaccination is not mandatory, where like the API program has been just started in the last 10 years only. It's very, very primitive program. The population in these countries, most of them, they are nomads. They don't have a specific place, they don't have addresses. So they are moving, and the borders between these countries are super porous. There are no borders. These borders are only on the maps. But the movement of the nomads between these countries is high. I can give an example. In October 2021, there was they were doing environmental surveillance for polio in Djibouti, and Djibouti, they took this certificate that they are polio free since 2006, and they suddenly found that the positive samples, and then they discovered that this is a child who was in North Somalia 2 weeks ago, and then he moved and came into Djibouti, and there are no borders, there are no checkpoints, there are nothing. So that's how the challenge, and the same challenge we are facing between, for example, Pakistan and Afghanistan. The borders are also in Peshawar and in these areas in Balochistan, they are completely porous. So one day people can be in Afghanistan, the second day they are inside Pakistan, and nobody knows, no passports, no check-in, nothing. So these are the kind of challenges that we are facing. So very well-developed API programs in Morocco, Egypt, Tunisia, Gulf countries, and almost nothing exists in other countries like Djibouti, Somalia, and Afghanistan. Another challenge we are facing, some countries in our region during the past 20 years, they don't have any official governance anymore. So for example, Afghanistan, 2 years ago, suddenly Taliban, they took over the regime. Taliban is not recognized regime by any country in the world. So we as UN system, we cannot deal directly with them. But what happened that since 2021 till mid-2022 for 1 year, all API programs, all vaccination had completely stopped, which was a crisis for the program that we were trying to push for years and years. So what happened that we were pushed to start dealing with some unrecognized regimes in order to train them, because they refused that any UN system goes inside their territories or deal with their population in a direct way. So we had to train them, first to convince them of the importance of the program, and then to train them to provide the service by themselves, because they don't have the trust in the UN system. For them, we are spies, we are foreigners, we are coming to know information about their places and so on. And many terroristic groups in Middle East, they don't really differentiate between US and UN. For them, UN is US. So, and I had this debate one day when I was in Pakistan. Like someone was telling me, you are here to know more information about organs. I told him, my name is Muhammad. I am from Middle East. I am not a European. I am not an American. I am not from anywhere. So I'm here to help you. But it takes time to convince them that we are not there for their benefit, and it's not for any other benefit. So those are the kind of challenges that we are facing. What we are doing, ImmuHubs can be very helpful in countries with stable security, for example, and receiving huge amount of refugees. Examples: Egypt receiving refugees from Libya, Sudan, and Palestine. Jordan receiving huge amount of refugees. They have the biggest camp for refugees from Syrian refugees, the Zahari camp, and also nowadays from Palestine. So these countries, the ImmuHubs can be very helpful. But countries like East African countries, it's almost impossible. They should have mobile teams, and that's what we try to working to implement. Mobile teams tracking the movement of the nomads, because they are moving into groups. They have always a chief. So we are not allowed to talk to anyone in the tribe without going first to the chief. This is the respect of the chief of the tribe. If he is convinced, then your job is very easy. If he is not convinced, you cannot touch a child in this tribe. That's why risk communication and community engagement is very important. It's super important. And during COVID-19, I was in Djibouti during COVID-19 when it started. I can tell you, if the DG of WHO, if the WHO representative in the country speaks for hours to the community, nobody will listen. You are foreigners, we don't trust you. But if you bring them someone from the community, a religious leader or a chief of the tribe, or for example, a figure that they really trust or like, a footballer or a runner or someone, marathon runner, because in East Africa they like marathons. This person, when he talks to them, he changed completely the percentage of the vaccination. Like in 2 weeks, we achieved 20 and 25%, while for 2 months we couldn't achieve 3 or 4% of vaccination in the country. So this is the context and how it's different from one country to another, and how we can use ImmuHubs in a stable, secure countries that are receiving huge amount of refugees.
How could the health survey maybe help? Because we were discussing some of that also in the EDCTP3 proposal. There are lots of pastoral communities in sub-Saharan Africa also who are moving. Question is, how digital are these people? It's at least the younger people, because if they can use a tool, no matter where they're moving, the health survey in particular will tell them, where they're accessing services and what do they need from their own viewpoint, where they are currently. That would be something to explore. But are they critical of any digital tools as well?
Yeah. One time I was deployed to the Tanzanian and Kenyan borders. I can tell you the situation in most of the sub-Saharan Africas is different from big cities to the rural areas. In the big cities, most of the youth in Africa now, they are highly advanced in technology. I have been to a place, Hirgiza in Somaliland, it's the northern part of Somalia. Actually, people are living inside small metal kiosks. But everyone from the youth, they have their laptop, they have all the technology. And one of the fastest internet in Africa was in Somaliland. And this was super, they don't invest in anything, but they invest in technology. So the same, for example, in Kenya and Tanzania, if you go to Nairobi, if you go to Dar es Salaam or something, the technology is highly used by the youth. You can use mobile apps, you can use everything, and actually they are using it in their daily life. But for example, when you go to the borders, I was with the Maasai tribes. Of course, these people, they don't have anything to do with technology, but the teams who will be deployed there, there are no internet connections, but they can use apps that collect data and they can reflect it on the system once it is connected. So offline apps are very helpful, and we actually used it when we went to the borders between Ethiopia and Djibouti. We used some kind, and UNICEF also, they are just during the last 3 or 4 weeks, they started to develop some apps that they accept offline data, and once you are connected, they are reflected. And WHO, for the past 15 years, we have been using eWarn or eWars, sometimes the early warning alert and response system. This is like an app to collect surveillance data. We used it in our region in Somalia. It has been functioning for the past 10 or 15 years. We use it in Yemen, we use it in Iraq, Syria, in 5 or 6 countries. And it's helpful that it has an offline version. Once connected, it reflects on the system.
So ironically, we've done that with the Vivi Score app in the first iteration in Berlin, because they put us with the flu patients into a room that had no windows, no internet, and no phone connection. So you're in the middle of Berlin, that can happen to you. But anyway, in the EDCTP3 project, we partnered with a small SME in Berlin that's called Solar Kiosk. So they create actually solar-powered vaccine refrigeration, and at the same time a place where you can get a drink and where you can charge your phone, or to get people to these places where then they could get vaccinated. So my point only is, in the future, maybe it'll be easier to be in track or in touch with mobile communities through mobile communication, and then help the people who come into the field to know where they need to go. Rather than, and I think that's what we learned in the ImmuHubs project in general, rather than expecting people to come to you, you try and come to where they are and pick up where their interest is. Whether it's a football conversation or a church visit or I don't know, whatever else draws people in will be good enough to start the conversation. Thank you so much.
Thank you.
We'll have more from you tomorrow, I think.
Yeah.
That will be very fascinating. So the idea is, can we pick these things up and use them elsewhere?
Thank you. My name is Paweł Zabolik and I'm representing the University of Rzeszów, Poland. And first of all, I would like to thank you for your words, that you have appreciated our work during, especially after the February 24th of 2022. Maybe some of you don't know, but our university, our city of Rzeszów is located 100 kilometers from the EU border to Ukraine, so like 100 kilometers from war, and we have guessed at around 2 million refugees from Ukraine, which was very challenging for us, but thankfully we somehow get it through. And I wanted also to underline the contribution of our modest colleague, Adam Seeger, and he's the head of the province sanitary and epidemiological station, and this station had actually organized, had made a substantial contribution to organizing the 3 ImmuHubs that we have been working on in our province in Superpelican Voivodeship in Poland. And of course, I can say many things for an hour at least about our work, but I want now to focus on the Ukrainian refugees, war refugees, that you actually are probably the most interesting group here, because the solutions that we have actually produced during the ImmuHub can be adopted for some further studies. And actually, our university, like I am representing the College of Medical Sciences, but we also have some other colleges, and the College of Social Sciences of University of Rzeszów is now working on a big grant and survey on assessing the socio-economic implications of that huge migration of people from Ukraine. And I think that, for example, the backup or some kind of modified application could be very, very important here to collect the data, and also to manage the issues that might happen during this survey, this application. And I would love to invite you in the 5th International Human Rights Congress that will take place in Rzeszów from 10 to 12 December of 2024. I would love to share your experience about the public health, about the vaccinations, and also the human rights from many talks from many different countries. So I encourage you to come to Poland. And so thank you. That's the main part of my speech here. But I wanted also to ask Mohamed, because you said that in Egypt the vaccinations are like absolute mandatory. So, and you said about BCG, and also my scientific interest is somewhere around tuberculosis. So, what is the incidence of tuberculosis in Egypt? Is it a real public health problem or not?
The BCG, like the tuberculosis, was causing a public health problem in Egypt in the 80s and early 90s due to the smoke of shisha. And the huge amount of the population was smoking shisha and using the same pipe from one person to another. So they solved this problem by using disposable pipes. So you use one use and then you throw its plastic pipe. Previously, they were depending on cleaning the pipes and then reusing. Of course, you cannot depend because they don't clean. You just put some water and
okay.
So now it's much lower. But in our region outside Egypt, we have a big problem in East Africa. We have a problem also in Pakistan of tuberculosis. High level of
Now it's a ecological problem of the plastic disposable things. But that's another thing.
Yes, another issue. You solved one thing, you have
that's interesting. Like smoking shisha is not popular in Poland, so that was an interesting answer for me as a European. I have never been to Egypt, so thank you.
Okay, so if I'll take the view on what ImmuHubs could be utilized in future, and I think we touched upon it on digitalization. That, like you said, in the east of Africa, you have digitalized services and everybody's using phone. And I think we should think on what the backup, when it's tailored, could then converge closer to the health services that are being digitalized very, very rapidly in our countries, on how they could be part of it, and the data that's being collected by an individual then could be merged with the data in the data repositories, both to be accessible to the individual himself, herself, but also for the healthcare personnel. And that's actually where we had difficulties in Finland on doing the kind of the health survey, because there already was a digitalized platform for it, and to add one more app to it, app being a medical tool, which is very strictly legislated, and it would have had to go through a very tedious process. But I think this is something that we need to have a look into, and how these apps that we have developed, how they are merged with the system in place, so that they are not individual in silo tools, but that they actually become the tools that then can send the reminders to people. Right now, for example, we do have an infectious disease register and vaccine register in Finland, where the individual can go back to 2009 to check his or her vaccine status. So that is then doable, and how we put the backup on top of that, so that it can serve both in the acute situations with your health and signs and symptoms that you score yourself, and then have the health data in there. So I see that that's the way forward that we would need to think with the European Union, the R&D, and the DG Sante people on how we work on that, so we get out of the silo situation where we are in right now. And then you mentioned, Barbara, the AFRA, on if that application is approved, then there is the kind of looking into how the apps can be working in the AFRA situation in those 3 countries. So I think that's probably something that I thought that the digitalization, the artificial intelligence, how we make the best use of those, rather than on the dark side use, which seems to be taking off the ground much more rapidly than what we're able to do here on the light side.
I've seen, and I still have 1 year, and a lot of my training is done in the US, and I've just come across an email one of these days from the FDA that they're starting to work on health hubs that are supposed to get people's homes, and talking about digital tools. I know that the FDA, they even gave me the regulation at the time, that they've been working high speed on regulating the space of health tools, digital health tools. This was in the middle of the process when we did the critical path innovation meeting in Rockville. These people were in the room. So I think there's also a lot happening in the US in terms of, I sometimes call it self-critically getting rid of the middlemen sometimes. Okay, that's my favorite anecdote that I would like to share at the end of this day was my mentor was, he passed from COVID in Zimbabwe in 2021, and he was a really leading figure on health system strengthening, really, before it was hip, so to say. And he was an HIV expert at Stanford and been working with us for decades. And we were driving in the remote countryside of Zimbabwe one time, going to the northern border, close to Mozambique. And he pointed out to me, there's a village over there that has the best outcomes of HIV, people living with HIV/AIDS in the whole country, and probably in all of Southern Africa. And I said, wow, what's the ingredient? What's the magic ingredient? How did they do it? And he said they got rid of the medical doctors. I thought this coming from a medical doctor at Stanford was quite humiliating, and it got me thinking, because what they realized is there were people living in this village who had a disease that's still a huge taboo. There's a lot of homophobia there, a lot of other issues. And having to go through the doctor with all of your appointments meant that they had to take 3 different days off per week, maybe, per month sometimes. And they would be known by their employers that there was something wrong with them because they had one appointment with the radiologist, one appointment with the lab, one appointment with the internist, one appointment with the infectious disease doctor. And that kept people away from the system. Getting rid of that and having it run kind of like you have your Finnish health nurses, for example, having it run by a nurse practitioner nurse who is keeping the feet on the ground, who is the known face that Adam was mentioned, can be a staple for replanning some of the outward-facing health services. In the US, some of that has been accomplished after Obamacare with having these FQRCs, federally qualified health centers, that look like a little barbershop. And they're in the middle of nowhere, in the middle of the community. That's where we did the SCORE app in our last iteration. So this got me thinking. So I think the positive side of digitization can be to empower people to report their needs directly without having to go through a middle person who may or may not understand what they're saying. And then moving the doctor back at the side of the patient in strengthening their voice. Is that an image that could work? Because that's what we meant when we said patient directly reporting clinical outcomes of clinical trials, for example, or reporting their needs, if need be, anonymously and safely, or trying to get their own control over their vaccination record with so many vaccines being recommended or not at the moment. So giving people back the power of figuring these important things out for themselves with the help of the medical professional is, I think, the vision that I would have for the future. And I hope that the tools will help to create these interfaces also. For example, I score my symptoms. It's been going so, right? So many diseases start at home. I think that's the idea of this FDA Health Hub at home. That's where many decisions are taken, and sometimes the wrong ones. So you will hear tomorrow from Families Fighting Flu. One of their members joined the Vivi think tank. She lost her 2-year-old son to influenza. She's a scientist herself. Her main question is, could I have done something differently? These very early moments at home. Am I going to go somewhere after hours? Am I going to sit in the ER? Or am I going to try and make it through the next night? Who's helping me then? That's pretty lonely, these moments, and they're important for prevention, treatment, and management, and diagnosis. So my positivistic view is to use digital tools as a communication enforcer, but not replacing the communication, but something that extends the duration of your doctor's visit until you're back home and now things are getting worse. So you can score again, send that back to your doctor and see what they say, right? Rather than feeling like, okay, now I'm back on my own again. So that's, I think, what I hope these tools will be able to do, and we're open to your feedback on how to get there.
Just one common question on this topic of apps. So last week I was at the Charlotte Van from Lessons Europe. Sorry, I haven't introduced myself. I was at the EIT Health Summit last week in Rotterdam, where digital health is really the focus. And it was really interesting to see everything that's happening in this field. I think this is another signal that we need even more interdisciplinarity, so working together across the sectors. And one topic that came up that I thought was really interesting, and maybe for this week is something to look into, is there's a plethora now of health and wellness apps. How do we know which ones we can trust? And I think this topic of trust comes back here. And I have it here, I'm happy to share it. This is something someone gave me at the EIT Health Summit. It's called Label to Enable. And it's in order to support the multi-stakeholder implementation of standards for the health app quality label. And so they have this little fiche that kind of gives criteria for ranking the app in terms of, has it been qualified? What is it easy to use, secure data, robustly built? And I think this is something that really needs to be implemented. And yes, we see that a lot of progress is being done in other geographical areas. I really have a lot of hope that in Europe, with also our diverse experiences, we can maybe make progress on this. So love to hear if anyone else on the panel has comments on this.
Just on this, I think the FDA regulation is one that you're mentioning. The EMA meeting that we had was very different. It was less IT oriented, but our plans to go back there. They assessed Vivi to see if we were an SME, but we're not commercial enough for that. So the next request was for us to write to their leadership to ask if we can be exempted from their consultation fees or something. But we're in dialogue with them because we're in the scientific camp in the community of respiratory viral illness. There's a complete lack of outcome measures that are patient-centered, and especially that are feasible in children and adults. So this is something we have on our mind, and I agree that there's a lot of nonsense out there that's never been studied or validated or published or critically appraised. From the merging of data viewpoint that both of you mentioned, one thing that we have foreseen relatively early on, and that was a piece of coincidence, is one of the founding members of the Vivi scientific think tank is Brian Kissler. He's the co-founder of CDISC. And that's, I don't know if the nerds of us know it, it's the Clinical Data Standards Organization that creates all the clinical data standards that are required for clinical trials. And they forced us and made sure that we would make sure that whatever data we collect are mapped to these data formats, terminologies, and standards. And there are also standards that bridge between ISO and ICH, and I don't want to bore you with all these acronyms, but basically we worked on that from the very beginning of these different tools to make sure that the data terminologies, it goes down to detail, like when you ask about migratory status or race or ethnicity, you can't just make that up on the go. You have to go by certain terminologies and how you ask this so that it will be compatible with, US CDC, the FDA, the EMA, and all these other organizations. So that's one way of improving the quality, and interoperability is the buzzword here, of digital tools to make sure they can serve clinical trials and so forth. We had, and I think you were at that meeting, Mohammed, at the ECDC, a meeting with ICERF in 2019, where we talked about clinical outcomes and how they can be defined in this wishy-washy world of respiratory viral infections. And one of our postulates was, why should the clinical data scrutiny be higher in a clinical trial than in routine care or in epidemiological surveillance? Who hinders us from using the same outcomes in all three so we can learn from each other's data? So there's, going back to that, I think there's a big need to make sure these things are happening. I'm sure that the people who are working on the foundation of this European endeavor are aware of those standards, but many people who create mobile apps are not. So that's one of the things on the nerdy side that we need to think of. Okay, I think everybody's hungry for the dinner. I think the TV screen turned hungry too. I think I unplugged it unintentionally, but that's all. All right, for tomorrow we'll fix it. First of all, thank you to the team here that's been supporting our work here and the visibility of this meeting. Jesus, what was the highest number of participants we achieved today?
So we reached around 130.
130 online visitors. All right, guys. So online and offline, please, everybody send a live tweet today and continue the conversation on social media. You get exactly an hour and a half until dinner to do that. And you don't need to change your clothes or anything. As long as you send a live tweet, we're all happy to welcome you for dinner. Thank you all. Thank you.